audience to kindly stand up for the invocation song. We request the audience to take their seats. I would now like to invite Dr. Srijit Parameshwaran, Professor and Head, Department of Nephrology, Jipmer, to deliver the welcome address. Sir, please.
Good afternoon, everyone. First of all, I would like to thank everyone for deciding to spend your weekend here in Jipmer along with us rather than spending at home. I hope we'll be able to compensate for that with the content of our academic program. The Jipmer Nephrology update is not something we are doing for first time, but you may not know that the department here started in the year 2010, and from 2011 onwards, every year we used to have a CME, usually one day, usually a team-based one, and we used to have faculty from different parts of India as well as abroad also, but then it used to be a relatively small affair, and this used to happen every year till 2017. 2017 we had the South Zone conference also organized in Jipmer by us. For various reasons after that we have not been organizing this annual update, and we have decided to restart from this year. Then again for a reason, that's what I am coming to. We have always been a very skeletal department for a long time. We are completing 15 years by January. There were only two of us as faculty here, myself and Dr. Priyamvada. And the services, of course, have grown, I would say, tremendously over the last 15 years. But now we are in a better shape with, in 2024, I think is a pivotal year for our department, where we have 3 new young energetic faculty who has joined the department, and the conference we are having, the meeting we are having today is also a manifestation of that change. We have Dr. Sabrinath, Dr. Karthikeyan and Dr. Swati who has joined the department as assistant professors. Dr. Sabrinath is the organizing secretary for this conference, as you would have noticed. Dr. Karthikeyan and Dr. Swati are also involved in organizing the program. Dr. Karthikeyan is also a faculty. Dr. Swati will be our quiz master. So along with, it's not only about the conference, we are hoping that the department has been doing, be it clinical service or training or to some extent research activity. We have been doing many things. The clinical service, I would say, if you look at the spectrum of services, has largely been complete, I would say, but then I think there is room for doing things in a better way. So I hope from now on, with more faculty in the department, younger people coming in, we'll be doing things whatever we are doing in a much better way. The conference we are organizing also is bigger compared to what we have been doing over the years, and we have a panel of eminent faculty from all over the country, as well as from a couple of people from abroad, and I'm sure you will find the proceedings enriching and a good learning experience. We intentionally designed the program using real life cases. You must have seen in the brochure case summaries. These are all real cases which we have had in Jipmer. We intentionally did that because I thought that will make the exercise even more memorable, and you will retain the information, and the intention is to make sure that the learning is also clinical oriented, that you discuss real life patients and discuss real life issues, and then also discuss how we investigate and manage them. So that is something which we did deliberately in having cases and to center the discussions around cases. So I hope that I believe that the program will probably not disappoint you, but then we have not organized a program like this, and we have certain limitations when we come to organizing these things. So if there are any lapses in the logistics or in the hospitality, I beg your pardon. Please do bear with us. We will try to improve it next year, because I believe we should be able to organize similar programs regularly in future. With that, I don't want to delay the program. I would like to welcome each and every one of you. Speakers, chairpersons, delegates have come. Very eminent people have come from across the country. I would like to welcome each and every one of you to this program. Thank you.
Thank you, sir, for your insightful words. We will now proceed with the inauguration ceremony. We cordially request Dr. Anupama Kaul, Dr. Gomati, Dr. Satish Balan, Dr. Srijat Parameshwaran, Dr. Priyamvada, Dr. Shabrinath, Dr. Karthikeyan, and Dr. Swati to come on to the dais for the lamp lighting ceremony.
Thank you, sirs and ma'ams. We shall now begin with a brief overview of the agenda. We have a total of 7 sessions planned for today, followed by paper presentations and the preliminary round of the quiz, following which we'll break for dinner and an alumni meet. Tomorrow we shall begin with the final round of the quiz, followed by poster presentations and 7 sessions, concluding with some interesting cases. We now begin with our first session, titled Kidneys, the Pregnancy Edition. This session will cover the anatomical and physiological changes in the kidneys during pregnancy, interpretation of lab tests, imaging of kidneys, and the clinical implications. The session will be chaired by Dr. K. Kumar, HOD of Nephrology at Indira Gandhi General Government Hospital and Postgraduate Institute, Pondicherry, and Dr. Sandeep Morkhandikar, Consultant Nephrologist at Ruby Hall Clinic, Pune. We request the chairpersons to occupy the dais.
We now introduce our esteemed speaker for the session, Dr. Karthikeyan M., Assistant Professor, Department of Nephrology, Jipmer. Sir has completed DM Nephrology from PGI MER Chandigarh in 2022, following which he worked as Assistant Professor of Nephrology at AIIMS Bhubaneswar in 2023. His area of interest lies in obstetric nephrology. Sir, please.
Good afternoon, everyone. I shall be discussing the physiological and anatomical changes in kidneys during pregnancy. So, in pregnancy, almost every organ system there are changes which are both anatomical and physiological, just to meet the increased demands of the growing fetus as well as the mother. The changes are both anatomical and physiological. The physiological changes include hemodynamic changes in the overall cardiovascular system as well as in the kidneys. With respect to kidneys, there are changes in both glomerular function and tubular function. Familiarity with these changes are very important to interpret the labs in pregnancy, and most of these changes return to non-pregnant state by 6 weeks after delivery. So coming to anatomical changes, there is an increase in the length of kidneys by 1 to 1.5 centimeter. What causes the increase in length? Maybe some increase is because of the hydronephrosis, but there are a subset of patients in whom even without hydronephrosis, there is an increase in kidney length. But definitely there is no increase in nephron number. Kidney volume increases by up to 30%. There is a massive increase in plasma volume during pregnancy. This causes an increased renal vascular as well as an interstitial volume, which causes the increase in volume. There is dilatation of pelvic calyceal system, which may be seen as high as up to 80% in pregnant women. So it is more prevalent with advancing trimester, more common on the right side. The explanation is maybe because of the hormone progesterone causing dilatation of the pelvic calyceal system as well as the ureters. But this doesn't explain the more common occurrence of hydronephrosis on the right side. And that is explained by the gravid uterus. The dextrorotation causes obstruction of the ureter, then leading to hydronephrosis. This is a study which was conducted in the late 1990s in Brazil. So we now know that there is a hydronephrosis. So up to how much level of pelvic calyceal dilatation is physiological, and after which it is pathological? This question is answered by this study. What they have done is they have measured the diameter of pelvic calyceal system of around 1,400 pregnant women. You can see on the left, above is the right kidney, below is the left kidney. You can see that the hydronephrosis severity is more on the right kidney. On the x-axis, this is the period of gestation. So with advancing gestation, there is an increase in the pelvic calyceal diameter. You see on the right kidney, the 90th percentile is about 20 mm, which is reached by around 32 weeks of gestation. Whereas in left kidney, the 90th percentile is only 8 mm, which is reached around some 20 to 24 weeks of gestation. So on the left side, you can see the ultrasound image showing the pelvic calyceal dilatation. Right side, there is a schematic which shows the gonadal vessels crossing the ureter, and this is also one of the reasons that is quoted for more hydronephrosis on the right side. This was a case which was published in New England Journal. So 19-year primey presented with symptoms suggestive of pyelonephritis. So they did an ultrasound which showed pelvic calyceal dilatation of 23 mm in the right kidney, which according to our previous discussion, with 22 weeks of gestation, this 23 mm is somewhat beyond physiological. So they went ahead with a intravenous pyelogram which showed dilatation of the proximal ureter and pelvic calyceal system on the right side. And they were able to notice a structure which is nothing but the fetus head compressing on the right pelvic calyceal system. They made the patient to lie in left lateral position, and after a few weeks the hydronephrosis resolved, and they gave antibiotics for pyelonephritis. This is just to know the physiological and the pathological limits of pelvic calyceal dilatation. What are the other anatomical changes? There may be increased in the frequency of micturition in pregnancy. As such, polyuria is extremely rare in pregnancy. It may be because of increased fluid intake, maybe because of progesterone effect, which is causing dilatation of the entire urinary tract, and the last, in advancing trimester, because of the enlarged uterus, there is a congestion in the pelvic viscera. So because of the congestion, the bladder capacity is less, so that frequent urination may happen. But as such, polyuria is extremely rare in pregnancy. So coming to systemic hemodynamic changes happening in pregnancy. So before that, we'll just see the basics. Arterial pressure depends on two factors. One is peripheral vascular resistance, and other thing is cardiac output. Pregnancy is a state of vasodilation. So in addition to vasodilation, there is also an increased vascular compliance. So both of these lead to a decrease in peripheral vascular resistance. Now, pregnancy is characterized by increase in heart rate about 20 to 30% above the baseline, and there is also an increase in the stroke volume. This is because of the massive plasma volume expansion that is leading to increased venous return and leading to increased end diastolic dimension, and according to Frank Starling's law, the stroke volume increases. Now with heart rate and stroke volume increases, naturally the cardiac output also increases. But despite the peripheral resistance is low and cardiac output is high, the overall arterial pressure decreases in pregnancy, with its nadir in the second trimester. Another point to note, there is an increased cardiac output and there is a decreased peripheral vascular resistance. So there is an increased perfusion in almost every organ, that is reflected by increased renal blood flow, and it has implications in our kidneys also. So this is what I discussed. So there is a decreased afterload because of the decreased peripheral resistance, increased preload because of the salt and fluid retention. So as a result, there is increased cardiac output and increased oxygen delivery. This is exactly what we have discussed. So this is a study which was conducted in 52 women to depict the cardiovascular changes in pregnancy. On the left, you can see the mean arterial pressure, which is lowest in the second trimester and increases towards the term. And here on the right, you can see the cardiac output increasing to around 6.2 liters per minute in second trimester and decreasing towards the term, and peripheral vascular resistance is decreasing with its nadir in the second trimester. So summarizing all the things which we have discussed, the systemic vascular resistance decreases to 30%, blood pressure decreases by 20% in the mid trimester, heart rate overall increases 20 beats almost the entire duration of pregnancy, cardiac output increases by 50%, the total body water increases by about 6 to 8 liters, and the plasma volume increases above 30% of baseline. Renal blood flow also increases, which has a reflection in the glomerular filtration rate, which increases up to 50% above baseline. Now, this is a study which was conducted in 11 pregnant women, out of which 9 had a successful pregnancy and 2 had an abortion. So this is a graph showing the 24-hour renal creatinine clearance. You can see that as early as 4 to 6 weeks, the 24-hour urine creatinine clearance started increasing, whereas that effect was initiated in those patients who had abortion, but because of abortion, it got terminated. So this is a systematic review and meta-analysis which confirmed that GFR was increased by 50% in physiological pregnancy as early as first trimester, and it is maximum at around 36 to 46 weeks. Because of this increased GFR, our serum creatinine level goes down by 15 to 20 weeks. Now the question is, what causes the increased GFR in pregnancy? So here it's the glomerular capillary. This is the Bowman's capsule. So this is the afferent arteriole. Now we have seen increased cardiac output and decreased peripheral resistance. That will lead to increased renal plasma flow. As the plasma flow increases, naturally the filtrate also increases, so the glomerular filtration has increased. So the next question is whether the glomerular hydrostatic pressure increases during pregnancy or not. If you can see in the diagram, the afferent arteriole and efferent arteriole are dilated almost to the similar extent. As such, there is no increase in hydrostatic pressure in pregnancy, and that is the reason you have, despite multiple pregnancies, mothers have a preserved renal function because the hydrostatic pressure, there is no intraglomerular hypertension. But the glomerular oncotic pressure goes down because of the dilution caused by the plasma volume expansion and the subsequent reduction in serum albumin. What is this Kf? We will come to this in the next slide. So this is the GFR equation, which is the delta P is nothing but of hydrostatic pressure and pi Gc is the glomerular oncotic pressure. This is Kf. Kf is nothing but of glomerular ultrafiltration coefficient. It depends on two things. One is the surface area, filtration area, surface area, plus the hydraulic permeability. These two things are determined by Kf. With advancing pregnancy, there is an increase in the Kf. That is also one of the reasons for increased GFR in pregnancy. So this is what we discussed. Filtration fraction is nothing but of GFR by renal plasma flow. So this is the graph. Now I want you to concentrate on this black line, which is the GFR. You can see the GFR increases and reaches its peak by mid-pregnancy, and it's maintained constant throughout the pregnancy, whereas the renal plasma flow has decreased in the second part of pregnancy. So in order to maintain the GFR in the second trimester, despite a fall in renal plasma flow, the filtration fraction has to increase naturally, and that is what depicted in this graph. Next thing is which is the best way to measure the GFR in pregnancy. They have compared almost all the equations. Among all the equations, the precision for measurement of GFR in pregnancy was maximum with 24-hour creatinine clearance of GFR. So all the MDRD equation, CKD EPA equation underestimated the GFR, and cystatin levels in pregnancy were increased in the second trimester, which is against the increased GFR that is observed in the second trimester. Now the next question is, what causes vasodilation in pregnancy? So this is just an experiment which was done in the pregnant woman. So this experiment was conducted to find the dose of angiotensin II which is required to evoke a pressure response. If you can see in the non-pregnant people, the mean dose of angiotensin II is very less. But in pregnancy, as the gestation advances, the dose of angiotensin II required to evoke a response, that is pressure response, is increased. This indicates that there is a decreased vascular response to vasoconstrictor like angiotensin II in pregnancy. Another hormone which is implicated in the vasodilation of pregnancy is relaxin. So relaxin is nothing but of a peptide hormone which is secreted by the corpus luteum. So it increases as early as the luteal phase of menstrual cycle and reaches its peak at the time of conception. Later, it reaches a plateau level during which the production is from the placenta. On the right side, this is an experiment conducted on the rats, pregnant rats. I want you to concentrate on the last two diagrams. So this MCA1 is nothing but of a rat relaxin neutralizing antibody, whereas this is a control antibody. If you see that though pregnant rats who has received a relaxin antibody has a decreased GFR, decreased renal plasma flow, and an increased renal vascular resistance. So this is what we discussed in the previous experiment. So whenever the relaxin was administered chronically to rat, all those changes which we see in pregnancy is observed. Whereas on the right side, if ovarectomy is done, the exact opposite changes occur. Here you can see the relaxin administration to rat is exactly similar to the hemodynamic changes that is happening in the pregnancy. So maybe relaxin is the one which is causing vasodilatation and increased GFR in pregnancy, but whatever thing that was observed in rats was not exactly replicated in humans. One example is that in assisted reproduction, where the ovum was donated, where there is no corpus luteum, despite there is no relaxin, there is an increase in GFR which is observed. So it is not only the relaxin which causes the increased GFR, there may be other mediators which causes the increased GFR. This is what we discussed, vasodilatation in pregnancy. The predominant role is from relaxin, maybe the decreased pressure response, and the nitric acid role is somewhat controversial. Next, coming to the tubular function. So many of the guidelines say that 24-hour urine protein more than 300 milligram per day is abnormal in pregnancy. We will see what is the normal excretion of protein in pregnancy. You can see this is around 250 women where they have seen the 24-hour protein excretion depending upon the trimester. If you can see, the mean is somewhere around 100 and the 95% confidence interval is around 260. And that is the reason they have kept more than 300 as this thing. And this is another experiment where they have seen the UPCR measurements over the twin pregnancy as well as the singleton pregnancies. You can see with advancing trimesters, the protein excretion increases, and also it is more in the twin gestation when compared to the singleton pregnancies. So what causes increased protein excretion? One is naturally the increased GFR, which is observed in pregnancy. The second thing may be because of alteration in glomerular charge, and the third one may be the anti-angiogenic factors which increase at the end of trimesters. For example, this is a study in preeclampsia patient where they have shown that SFLT concentration increase is more in the preeclamptic woman. But even in normal women, towards the end of the gestation, the SFLT concentration has gone high. So this causing disruption of the podocyte slit diaphragm is also one of the mechanisms for increased increased proteinuria that is observed in pregnancy. So this is next thing is glycosuria. So the excretion of glucose increases 10 times the non-pregnant value. So what is the reason for that increased glucose excretion in pregnancy? Here you can see on the right side, here there is a plasma glucose concentration and the glucose reabsorption on the y-axis. So there are three curves. One is the filtered load, another one is excretion, another one is reabsorption. Here you can see the threshold. Threshold is defined as the plasma glucose value above which the glucose will appear in the urine. Okay, so there is no change in renal threshold of glucose in pregnancy. So then what causes glycosuria? The next thing is, it is either because of the increased filtered load of glucose, which happens because of increased GFR, or because of the decrease in the transport maximum. What is transport maximum? Transport maximum is the rate, the maximum rate at which the tubules can reabsorb the glucose. If you can see here, it is around 375 milligram per minute. If it exceeds beyond this, the tubules will not reabsorb the glucose and it will be excreted. So both of these, that is decrease in Tmax as well as the increased filter load, both may contribute to renal glycosuria. Other changes, uric acid lowered in the first half but increases towards the non-pregnant value. In the first half, it is because of increased GFR as well as the decreased proximal tubular reabsorption. Calcium excretion also increases, but because of the nephrocalcin and Tom Horsfall protein concentration, there is no stone formation literally in pregnancy. Now coming to the electrolyte balance, total body sodium increases by 1000 milliequivalents, potassium increases by 320 milliequivalents. But despite this, serum levels of both electrolytes decrease during pregnancy. Sodium decreases by 5 milliequivalents, potassium decreases by 0.25 milliequivalents. How this happens, we'll come to this. So there are natriuretic factors and anti-natriuretic factors which are acting in pregnancy. The factors which are responsible for increased sodium excretion is increased GFR and increased sodium filtered load. Second is increased atrial natriuretic peptide and progesterone. Progesterone goes and competitively inhibit the mineralocorticoid action, so it is natriuretic. What are the anti-natriuretic factors? One is aldosterone, which is going and binding to the aldosterone receptor, causing increased sodium retention because of the RAS activation. Next, the deoxycorticosterone, which is produced from the progesterone by 21 hydroxylation. It's more of a mineralocorticoid and acts on the aldosterone receptor. So these are the anti-natriuretic factors. Among both natriuretic and anti-natriuretic, it is the anti-natriuretic factors which will predominate, so there is a net sodium retention happening in the pregnancy. But if there is a net sodium retention happening in the pregnancy, because of the RAS activation, why not the potassium has not decreased? That is because of the anti-caluritic effects of the progesterone. So now, as I discussed, sodium goes down in pregnancy, osmolality also goes down in pregnancy. Why this is happening? You can see this graph. This is a pre-conception, this is the pregnant state. You can see in the pre-conception, it is a 290 osmolality, the vasopressin is secreted. Whereas in pregnancy, even at 275, the vasopressin is secreted. So the osmotic threshold for AVP secretion decreases in pregnancy. So this causes preferentially more water retention than sodium retention, and that is the reason, despite an overall sodium increase in the body, the plasma sodium level is low. There is a rare condition, diabetes insipidus of pregnancy. Vasopressinase is an enzyme produced by placenta. It degrades the antidiuretic hormone. It is very, very rare. In the mid-trimester and third trimester, if it completely destroys the ADH, there may be diabetes insipidus. Treatment is desmopressin, which is resistant to vasopressinase. So the last slide. So coming to the interpretation of laboratory values during pregnancy, hemoglobin, there is a physiological anemia of pregnancy because the plasma volume expansion is more than that of the RBC volume expansion. Urea and creatinine goes down because of the increase in GFR. Sodium goes down because of preferential water retention by reduced ADH threshold. Potassium remains almost the same, and uric acid in the mid trimester it is low, whereas later part it increases towards the non-pregnant. pH, there is a respiratory alkalosis happening in pregnancy. This is because of increased minute ventilation that is happening in pregnancy. So PCO2 is also washed out around 27 to 30. Bicarbonate decreases because of the washed out PCO2, and serum osmolality also decreases because of the reduced ADH threshold. So this is a summary. Thank you.
Good afternoon. Am I audible? Thank you, Professor Srijit, for giving us the opportunity. Dr. Karthik, it was an excellent presentation. Before opening a discussion, I just want to add a point. The existence and continuation of a mankind depend upon only one conditionality, that is women accepting the risk of pregnancy. Otherwise, if they don't accept the risk of pregnancy, humankind will probably meet an end. There are a lot of changes in women during pregnancy. The scalp, skin, their bones, joints, the cardiovascular system, renal system changes. My ophthalmology colleague says even their ocular dimension changes, their visual acuity changes. So women is not a single person, she has a future generation. Probably we have to teach our sons and students in school and college early so that like incident like in Calcutta happens should not happen. So women is not just pleasure, they are future generation. My question to Dr. Karthikeyan is, now with increasing age at pregnancy and the artificial fertility technique taking up a lot of impetus, the women are at increasing age during pregnancy. How are these physiological changes occurs in them, and especially in the context of multiple pregnancy?
So whatever changes that happens in the normal pregnancy is in fact exaggerated in the multiple pregnancies. Like multiple pregnancy, you mean twin gestation, right, sir? Yes. So that is exaggerated in the twin gestation. Whatever physiological changes is in fact exaggerated, and because of that, like be it plasma volume, be it GFR, everything exaggerates with even increased GFR, increased protein excretion, all is exaggerated. Nothing different from singleton gestation.
Pregnant at 40 and beyond, now sometimes people get pregnant at 50 and 60 also. Does these changes, is there any study to show that they also have happened?
I have not come across any studies like how the physiology behaves in advanced stage, sir. But I think so that there should not be any change in physiology unless they have any disease which prevents the normal mechanisms to happen.
Thank you, sir and ma'am, for giving me opportunity. Just for add on, my wife works in IVF, so I can add on these few things. So there are actually, sir, I'm being working in Pune. The average age of pregnant females has actually, if you ask me, has gone up at least a decade ahead. It's almost, I'll say, average age is around 35, 33, 35. They get their first kid, and most of the time, second kid is at the age of 40, around that. And fortunately, being I'm in the same setup or working in the same zone area, all these things, there is a really high incidence of PIH or kind of a thing, particularly in all these artificial reproductive therapies. I don't know the reason basically, but definitely they have been a lot of, you can say, acquired hormonal issues because of the injections which are like lupurides, GnRH analogs, anti-analogs. They are changed in cycles, like one cycle is analog cycle, another cycle is anti-GnRH cycle, and these do have changes in the body, no doubt about that. And if you ask me, I don't have the studies where I can, because being in a private sector I cannot do that, but definitely I'll say 50% will have medical issues, hypertension, GDM, whatever you can think of, all CNS or psychological problems because of also delayed and continuous cycles. Definitely the presentation, what we see, maybe another 20 years down the line, this will change. I can tell you for sure. Overall, the infertility rates, if you see of all over the world, they are really going down. They are not up, if you see, all over the world. And the reason are multiple factors. Stress, which is unaccounted in any of the studies. The workload, the working women's, again, if you see, once you go out of the, means in educational setup like this, the working population of women is very less who are getting pregnant. If you go outside, the working population who are getting pregnant is almost 90%. So all these changes do happen, and unfortunately, they are going to be changed in the whole physiology, what we learned maybe 20 years back, and what we're going to see in the future, particularly medical complications. Thank you.
Any questions from the floor?
While dealing with glomerular diseases in pregnancy, we always look at the complement levels. So, how does it fluctuate?
Complement levels in normal pregnancy.
Yes.
Generally, the liver synthesis, the synthesis of
So it's important understanding that patients who have lupus and they are remission before they become pregnant. So what do you do? How do you follow them up? Then how do you differentiate between a flare and a preeclampsia happening in them? I'll just show it in my slide, but what I'm trying to say is in pregnancy what happens is the complements are all on the higher side. So when they go down and the SFLT and endoglins are and the PIGF levels are higher, this suggests that this could be preeclampsia. But if the complements are going down and DSDN is rising, that means the flare is going to happen. That's how it happens. Pregnancy, the complements are on the highest.
Thank you, Dr. Karthikeyan, for the comprehensive session. We now request Dr. Srijit to hand over the mementos as a token of regard to our chairpersons and the speaker.
We shall now move on to our next session, which focuses on urinary tract infection in pregnancy. This case-based discussion will explore the screening, treatment, and outcomes related to UTIs in pregnant women. The session will be chaired by Dr. D.K. Subramaniam, Professor of Medicine at Jipmer, and Dr. Arun Kumar, Associate Professor of Nephrology at AIIMS Delhi. We invite our chairpersons onto the dais.
We invite our esteemed speaker for the session, Dr. Naveen Matewada, Consultant Nephrologist, Virinchi Hospital, Hyderabad, who is a proud alumnus of our Nephrology Department of Jipmer. Sir has successfully completed the European Specialty Examination in Nephrology and is a Glomcon Fellow with expertise in glomerular diseases. Sir, please.
Good afternoon, everyone. First of all, I would like to thank the organizing committee for giving me this opportunity. So, today we will be discussing about urinary tract infection in pregnancy. So, these will be the learning objectives of this discussion. So, we'll start with a case. This is a real life case which was treated at Jipmer. So, this is a 35-year-old female with diabetes, hypothyroidism and a psychiatric disease, and she was on lithium. And in February 2023, she presented to the ER with accidental abdominal knife wound, and at that time she was found to be 9 weeks pregnant. And she underwent laparotomy and wound repair, and subsequently the pregnancy was continued, and at presentation the creatinine was 0.8 milligrams per deciliter. And subsequently in April 2023 she was readmitted with fever and oliguria, and at that time her creatinine was 9 and she was started on hemodialysis, and urine analysis at that time was showing plenty of pus cells, and ultrasound was showing left hydronephrosis, and urine culture was showing E. coli. So she was started on antibiotics, and hemodialysis was continued, and degestant was inserted on the left side. Subsequently, she responded and her creatinine came down to 2 to 2.5, and she became dialysis independent, and the degestant was removed. And a repeat urine culture was done, which was showing MDR Klebsiella pneumonia, for which she was treated for 21 days with meropenem and phosphomycin. And pregnancy was continued, and subsequently it was uneventful, and she delivered at 32 weeks of gestation, and birth weight of the child was 1.5 kg. So here I would like you to make note of certain things. In February 2023, at 9 weeks gestation, when she presented, we don't have details whether screening was done for asymptomatic bacteriuria, and subsequently she was treated for pyelonephritis, and repeat urine culture was done after treating pyelonephritis also, and she was on treatment for 21 days. Whether this treatment duration was adequate, or whether something else could have been done, and what about the pregnancy outcomes, that is she delivered at 32 weeks of gestation, and the baby weight was 1.5 kg. So these will be our most important discussion points. So before going into the discussion per se, before preparing for this talk, we had a small online survey. Mostly nephrologists, obstetricians, physicians and urologists participated, and what it has shown is only around 20% of doctors are very confident in, either confident or very confident in treating UTI during pregnancy. So there is a scope for discussion, and I'll try to do my best to address some of the issues. So pregnancy and UTI, what is the link between pregnancy and UTI? Already the physiological changes during pregnancy were discussed just now. So there are certain factors which increase the risk of UTI, that is the dilatation of the urinary tract and decrease in the peristalsis. There is increased smooth muscle relaxation, and there is increased bladder capacity, and there is mechanical obstruction because of the gravid uterus, and there is it was discussed in the previous talk, there is glycosuria and alkaline urine pH, there is increase in the length of the kidney and GFR. All these factors, they contribute to the increased risk of UTI, and along with this there are certain other risk factors which can increase the risk of UTI, that is any previous history of UTI, diabetes which our patient has, and then low socioeconomic status, multiparity, advanced maternal age, high level of sexual activity, any urinary tract abnormalities, bacterial vaginosis, sickle cell disease. With regard to diabetes, most of the earlier literature says that gestational diabetes is not a risk factor for UTI during pregnancy, but recent literature, there is some evidence that even gestational diabetes increases the risk of UTI. And with regard to sickle cell disease, it is the reverse. The earlier literature shows there is increased risk, but recent literature shows the risk is not cannot be attributed to sickle cell disease, but there were other factors which have contributed. And along with that, if there is nephrolithiasis, then the risk of bacteriuria and urinary tract infection increases. This is two-way. The presence of kidney stones increases the risk of UTI, and if there is UTI with urea splitting organisms like Proteus or Pseudomonas, Klebsiella, this can increase the risk of struvoid stone formation. But luckily, the pooled incidence of renal stones in pregnancy is only 0.5%. But even with that, there is significant association between renal stones and UTIs, whether it is asymptomatic bacteriuria, cystitis or pyelonephritis, all had significant association, and there is association with preeclampsia. Then coming to the incidence and prevalence of UTI during pregnancy, the prevalence of asymptomatic bacteriuria in pregnancy is similar to that of any non-pregnant woman of childbearing age. It is around 2 to 10%, and if you look at the worldwide prevalence of UTI, it is 23.9% as per this paper published in 2023, looking at the global prevalence of urinary tract infection. And specifically, if we look at prevalence in India, it is 22.9%. And if we divide it into symptomatic UTI, 2.3% for cystitis and 0.5% for pyelonephritis. And looking at the microbiological spectrum, it is similar to non-pregnant women. Most common causes E. coli, which accounts for 70 to 80% of the cases. The others are similar to non-pregnant women. One special mention is about Streptococcus agalactiae, that is group B streptococcus, which accounts for around 10% of the cases of UTI in pregnancy, and it is associated with increased risk of chorioamnionitis and preterm birth. And the presence of Streptococcus agalactiae becomes an indication to provide peripartum antibiotic prophylaxis to prevent neonatal infection. So this is again the microbiological spectrum. Proteus and Pseudomonas, they increase the risk of struvoid stones. And then coming to the pathogenesis, it is similar to non-pregnant state. There is colonization, and subsequently the bacteria invade, and they subvert the host defenses, and they can form biofilms. But how the patient develops symptoms is not fully understood. How a patient with asymptomatic bacteriuria cannot have symptoms, but a patient with cystitis will have symptoms. This is not clearly understood. Then coming to the three forms which we are going to discuss: asymptomatic bacteriuria, cystitis and pregnancy. Asymptomatic bacteriuria, it is the name itself tells there are no signs or symptoms of UTI, but the diagnosis is based on culture positivity. This is a quantitative culture, more than 10 power 5 colony forming units, irrespective of the presence of pyuria, and there should not be any signs and symptoms suggestive of UTI. But when the patient develops typical signs and symptoms in the presence of bacteriuria, if patient develops urgency, dysuria, frequency, hematuria, then we call it cystitis, and the diagnosis of pyelonephritis is also similar to non-pregnant patient. The one point which we should remember is the symptoms like frequency, urgency and nocturia are common even in normal pregnancy in the absence of UTI also. So one thing that is more predictive of UTI is dysuria, and second thing is assessing the changes from the baseline. Rather than looking at the symptoms, we should look at the change in the symptoms that happened during the course of pregnancy. Then coming to the complications associated with UTI, why do we have to discuss all this? So there are both maternal complications and fetal complications associated with both asymptomatic bacteriuria and UTI, that is cystitis or pyelonephritis. Maternal complications are mainly pyelonephritis leading to sepsis and septic shock, preeclampsia, preterm labor, and fetal complications are prematurity, low birth weight, and neonatal sepsis. So coming to pyelonephritis, the incidence is 0.5 to 4%, and in cases of patients with asymptomatic bacteriuria, it is 2.4% if as compared to 0.6% in patients who don't have bacteriuria. And the pyelonephritis is more common during the second and third trimester. This is a point to be noted because the screening for asymptomatic bacteriuria is timed based on this. And pyelonephritis in pregnancy is associated with additional risks compared to non-pregnant women. So risk of AKI and sepsis is common in even non-pregnant women, but there is additional risk of ARDS, DIC, anemia, and preterm birth when it comes to pregnant patient. And this is a pooled analysis of rates of pyelonephritis in patients with asymptomatic bacteriuria, if they are treated and if they are not treated. So when they are treated, the risk of pyelonephritis decreases. This is from US preventive workforce statistical analysis. And coming to preterm labor, earlier asymptomatic bacteriuria was considered a risk factor for preterm labor, but this is mainly because it leads to pyelonephritis, and this pyelonephritis contributes to preterm labor. But with the introduction of screening and treatment, this risk has decreased. But still, if somebody has symptomatic UTI, then they are at higher risk for preterm labor. Here there is no significant association, if you can see, between asymptomatic bacteriuria and preterm labor and fetal loss, these things. And coming to other complication, preeclampsia. UTI is a risk factor for preeclampsia. It increases the risk of preeclampsia by around 1.3. This is a systematic review which included 19 studies, mostly observational studies, and it has shown that the relative risk increases, and here the odds ratio is 1.3%, and similar to this urolithiasis, preeclampsia also increases the risk of UTI, and around 6.8 to 7.7 times increased risk of bacteriuria is seen in patients with preeclampsia. Then coming to fetal and neonatal complications, low birth weight, there is a risk of low birth weight in associated with maternal UTI, and then neonatal sepsis. When there is Streptococcus agalactiae colonization, the risk of neonatal sepsis is 0.2%, and with regard to microbiological spectrum, E. coli is associated with neonatal sepsis compared to Klebsiella. So we have looked at all these maternal and fetal complications associated with asymptomatic bacteriuria and UTI. So it is imperative that we try to prevent these UTI and associated complications. So what are the various interventions that can prevent UTI? So hygienic measures is the one which is well established and where there is robust evidence. The other interventions like cranberry juice, antibacterial immunization, that is chemoprophylaxis, Canafron, it is a combination of 3 herbs, ascorbic acid, all these they are safe to use in pregnancy, but the evidence in preventing UTIs is not robust. And if you look at screening for asymptomatic bacteriuria, it is also a form of preventive measure where we are preventing patient from developing symptomatic cystitis or pyelonephritis. So, screening for asymptomatic bacteriuria, the role is here. So, whenever we look at screening, there should be some evidence showing that when we screen, there is a intervention, and that intervention should lead to positive outcomes. So, if you look at the evidence, if patients with asymptomatic bacteriuria are treated, the risk of development of pyelonephritis decreases. The relative risk is 0.24. The risk of preterm delivery is 0.34, and low birth weight is 0.64. So, there is evidence that treatment of asymptomatic bacteriuria decreases the complications. And this is one more systematic review that has shown that the risk of low birth weight, preterm delivery and preterm labor decreases. And with regard to small for gestational age, there is difference in the like geographical variations, where there is a significant difference in Americas, but in Europe there is no significant difference. So, with this background, we look at various screening strategies and how do we diagnose and treat asymptomatic bacteriuria. So, this was part of that survey where we have asked the participants whether they routinely advise urine culture. So, here 31% of respondents have responded as no, and 34% advised in each and every patient, and around 34% they decided based on the risk factors. So, what does the guidelines recommend is to screen all patients, all pregnant women in the first trimester. So, this is the guidelines recommended by various societies starting from 2018 to 2024. The recommendation is to screen and treat the pregnant woman in the first trimester or during the first visit to the healthcare personnel. If you look at the grading of evidence, like IDSA has downgraded the evidence from IDSA, this is a strong recommendation with moderate quality evidence, and United States Preventive Services Task Force, this has downgraded the recommendation from grade A to grade B. This is because the evidence is mainly from the older studies. Newer studies, they don't show significant association. So, how do we screen? 2 samples are needed to confirm, but in practice single sample is enough. Single sample has 80% specificity, while 2 samples have 95% specific. If we look at other modalities of screening, dipstick and all those, the positivity value is not significant, and one more advantage with cultures is they are useful in selecting the treatment regimens. So, culture is the gold standard for screening. Then once we have decided to do a culture, when do we advise it? So, this there was diversity in the responses. Most of them like 20.7% recommended it in the second trimester, but the IDSA guidelines recommend early pregnancy, that is before 16 weeks, because the risk of pyelonephritis is higher in second and third trimester. And rescreening, we'll discuss it later. And specimen collection, midstream urine is as good as clean catch urine, and I'll not go into further details. Midstream urine sample is enough, and early morning sample, clean catch samples are not necessary. And once we diagnosed asymptomatic bacteriuria, whether to treat or not, most of the respondents agreed on treatment, 96.6%. And with regard to antibiotic of choice also, most of them confined to what guidelines have recommended. This is the treatment of both asymptomatic bacteriuria and acute cystitis. Nitrofurantoin, cephalexin, sulfamethoxazole, trimethoprim, phosphomycin, amoxicillin and amoxicillin clavulinate. Each has its own advantages and disadvantages. So nitrofurantoin is the time tested. So you can look at all these advantages and disadvantages later on. So, and coming to the duration of treatment, there was diversity, but up to 5 days is the most common. But this is a Cochrane review from 2015, which has looked at the duration of treatment. This has shown that preferred treatment is at least short course and antimicrobials, that is up to 4 to 7 days of antimicrobials is treatment is needed. Then repeat culture, it is not recommended, and but most of them have responded as yes. But for cystitis and asymptomatic bacteriuria, repeat culture is not necessary if patient doesn't have any symptoms. But in case of cystitis, if patient continues to have symptoms, then probably we may adjust the antibiotics based on the culture reports. Then coming to treatment of pyelonephritis, where do we treat? Whether outpatient management is can be done. There are some studies which have looked at possibility of outpatient treatment, but only 2 trials are there, and those 2 are from the same group. But 51% of the patient did not qualify for the treatment. So it is prudent to treat the patient in an inpatient setting, and broad spectrum IV antibiotics should be started. And patient can be converted to oral antibiotics once patient is afebrile for 48 hours. And these are the various treatment regimens which are recommended for pyelonephritis. And if we compare these treatment regimens, there is no significant difference in the clinical response to the first 3 were compared in the
3 more minutes remaining.
Yeah. And coming to obstetric management of pyelonephritis by itself doesn't become a indication for induction of labor. So it should be treated, and once patient is afebrile, patient can be considered for delivery. Then secondary prophylaxis is considered if there is persistence of bacteriuria after treatment or 2 episodes of UTI, or if after a single episode of pyelonephritis, or if patient has history of UTI associated with the risk factors. These are the recommended antibiotics for secondary prophylaxis, and cephalexin should be stopped 1 month prior to the delivery. And this is a study showing the effect of antibiotic prophylaxis, which has shown that there is a significant effect. And the most important thing is antibiotic safety. So when it comes to pregnancy, we should look at the antibiotic safety also, especially when we are considering secondary prophylaxis. This is the study looking at the safety of the antibiotic prophylaxis. There is sulfonamides associated with anencephaly, all this. These are the various antibiotics and their associated side effects. Irreversible bilateral deafness, tetracycline is associated with tooth discoloration and bone anomalies, and similarly fluoroquinolones, tigecycline. So then coming to our case, February 2023, when she presented first, if she was screened for bacteriuria, probably we could have prevented pyelonephritis. That is one thing, because she is a 35-year-old, that is increased maternal age. She has risk factors, diabetes and psychiatric disorder. So she is a high risk candidate to begin with. She should have been screened in February. That was a missed opportunity. And then she went on to develop UTI. and that was managed effectively, but subsequently the treatment duration was only 21 days. Whether treating for longer duration, that is till the end of pregnancy, would have made any difference, that we do not know as of now. But the pregnancy ended at 32 weeks. Probably that preterm labor and low birth weight could have been prevented if we prolong the duration of treatment. So with this I conclude, and thank you for giving me this opportunity.
Thank you, Dr. Naveen. I do understand the topic is quite extensive. It could have been fragmented into two parts so that you could cover more extensively the management part. Anyway, I think I will have a show of hands. How many of you will give antimicrobial prophylaxis, secondary prophylaxis, after asymptomatic bacteriuria? Two. Okay. How many of you will give antibiotic prophylaxis after acute cystitis? Okay. I hope my question is there and you are thinking to respond or not to respond, no? And how many of you are thinking or will give prophylaxis after acute pyelonephritis? Fairly good enough. I think Dr. Naveen, your talk has been effective.
Yes.
Because frankly speaking, even in acute pyelonephritis, I am not very sure. As a physician, we have treated. I don't remember advising secondary prophylaxis. And mainly because I believe secondary prophylaxis only adds to resistance rather than anything else. So, and the doses they advocate also so low, I don't know whether it is very effective. But then, I would definitely say acute pyelonephritis in high-risk pregnancies or a precious pregnancy, they are definitely, after your talk and going through some literature, I feel there is a strong role for giving antimicrobial prophylaxis. Otherwise, I am not very sure whether we should give routinely patients of acute pyelonephritis with secondary profiles. I would like to ask our OG, I can see a few consultants around, what do they advise? Madam?
Bacteria, we might consider giving the secondary prophylaxis. In women who have had recurrent urinary tract infections, there, yes, we had one, it was treated, we had within a month another one also came up, then yes, there is a role for secondary prophylaxis throughout pregnancy.
But this precious pregnancy, nowadays, see a lot of pregnancy are very precious because late marriage and only one child and then high-risk pregnancies.
Yes, sir, definitely for the high risk who are elderly with a underlying medical disorder and with an acute pyelonephritis, there could be a role for secondary prophylaxis. But for a straight shot acute pyelonephritis in a low risk normal woman without any other problem, urinary tract malformation or anything else, it's not needed to continue the secondary prophylaxis.
What about, madam, about asymptomatic bacteria? Do you all screen?
Oh yes, for all asymptomatic bacteria we have to treat.
We
do that.
Regularly done screening?
Yes, yes, we do a regular screening and treat.
Thank you.
Thank you, Dr. Naveen. My only question will be that following an episode of complicated symptomatic UTI or pyelonephritis, what would be the frequency of screening for urine cultures?
Sir, following a complicated UTI, it is better to put the patient on preventive prophylaxis. If a patient had cystitis or uncomplicated pyelonephritis without any complications, then probably there are around 13 guidelines worldwide, but each of them recommend differently. Most common recommendation is to screen once every month.
That is what we usually follow. I think asymptomatic bacteria after treatment we usually don't screen again, whereas for symptomatic UTIs or pyelonephritis we tend to do monthly cultures and treat only if there is a culture positivity. Otherwise we don't do it. Any questions from the house?
for infection, or a culture is necessary every time? I think this is kind of coming up in its concept. I want to know your opinion on that.
There is one slide, actually, I'll go back to it. The positive predictive value of nitrite test is lesser than culture, and the advantage with urine culture is it can help us direct the antibiotic treatment. So this is the various urine dipstick parameters and microscopy parameters which were compared to urine culture. So compared to urine culture, all of them had lesser sensitivity and lesser specificity. Only nitrates was very specific, but the sensitivity is lesser. So nitrite negative, ma'am. So the sensitivity is very less. So nitrite negative, we are not very sure whether it is really there is no bacteriuria or not.
Even if nitrate is positive, a positive culture with sensitive antibiotics would be better. Negative also we usually do a culture.
Now, our general practice is we do a urine routine examination. We look for pyuria, nitrites, leukocyte. Only if there is positivity, we go for a culture. I think that has served its purpose for a long time. We are not routinely doing cultures for all pregnant ladies. Only we do a urine routine. If it's showing pyuria or nitrates or dipstick, then we do a culture. Okay. Otherwise, we don't do it. Because a lot of patients are there with pyuria which doesn't, and their culture is negative. So we don't have to treat. But doing culture alone, I don't know how commonly you get a culture positivity out of anything in the urine, unless the patient is neutropenic or something like that. So I don't think it's very, very likely that way.
Yeah.
Thank you, Dr. Naveen, for the enlightening session. We now request our chairpersons to kindly present a memento to our speaker. Sirs, please. We now request Dr. Priyamvada to kindly present a memento as a token of our regard to our chairpersons. Ma'am, please. Thank you. There are a couple of announcements to make. We request the delegates participating in the quiz to kindly register at the registration desk during the tea break. And we also request participants of the paper presentation today to submit their PowerPoint slides at the audiovisual desk.
Moving forward to the third session for the day on glomerular disease, hypertension and pregnancy. First, we will be discussing the management of new onset nephrotic syndrome in pregnancy. The session will be chaired by Dr. V. Jayaprakash, Professor and HOD of Nephrology Department at SRM Chennai, Dr. Myukta Vyavahare, Professor of Medicine at Jipmer Pondicherry, and Dr. Jittu Kurian, Assistant Professor of Nephrology at Pushpagiri Medical College, Kerala. We request the chairpersons to kindly come onto the stage and occupy their seats.
We invite our esteemed speaker for the session, Dr. Anupama Kaul, Professor of Nephrology at the prestigious Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Madam has 251 national and international publications to her credit. Her area of interest are pregnancy and kidney disease, lupus nephritis, post-transplant diabetes mellitus. She is the editor-in-chief of Journal of Indian Society of Renal Nutrition and Metabolism. Please, ma'am.
At the very outset, I want to thank the organizing committee to have given me a topic of very close to my heart. And you see, we as nephrologists and dealing with pregnancy and nephrotic syndrome, may be stronger, but a multifaceted approach makes us much stronger to deal with these problems. So looking back at the protocol case which was given to us, she is a 27 years old female, primary gravida. She's 17 weeks of gestation. What is interesting to understand is she had swelling, she had facial puffiness, she had proteinuria, her blood pressures were normal, her lab investigations showed a low hemoglobins, which was probably because of iron deficiency. She had a creatinine which was normal, albumin was 2.3, dipstick albumin was 3 plus, and unit PCR was 3.9 grams. The lipids were abnormal, the biomarkers were negative, AN and the complements were normal. She didn't give any history of kidney disease or proteinuria in the past. She was in regular antenatal checkup and previous records of blood pressure and proteinuria wasn't there. The ultrasound shows normal sized kidneys and she doesn't want a kidney biopsy. So what do we do? There are challenges and dilemmas here. The dilemmas are, is she having gestational proteinuria or is this an early instance of preeclampsia? What happens if it had been happening beyond 20 weeks of gestation? Would we label it as a primary glomerular disease or was it a preeclampsia happening to her? Then, whether there's a preeclampsia, she has a superimposed on a primary glomerular disease which de novo appeared during pregnancy. Diagnostic modalities, whether the 24 hours proteinuria is important or a dipstick is important, and whether we should have a conservative approach or a specific treatment. And challenges? Challenges are many. Do we biopsy her? Do we start her on anticoagulants? She had a low albumins. Do we give her empiric therapy or we have the pros and cons according to that? Early interventions, whether we have any effects on the maternal fetal outcomes. So these are the concerns, and let's go back to the basic problem. Now, nephrotic syndrome in pregnancy can be of varied etiology. See, the patient, these childbearing age women could have had proteinuria before she became pregnant, or it was a de novo proteinuria in pregnancy, which ranges about 0.1 to 0.2% of all the pregnancies. What is important to understand is timing of proteinuria. Suppose the proteinuria happens before 20 weeks of gestation, should we call as underlying glomerular disease, and something which happens beyond 20 weeks is it only preeclampsia. There was so much of data to talk about whether gestational proteinuria is just a favorable outcome. Thinking, understanding, there are misleading options as well there itself, because there is data to suggest almost 30% of patients who had gestational proteinuria progressed to preeclampsia. Causes of proteinuria in pregnancy could be multiple. It could be preeclampsia. There was a data way back in 1970s where they biopsied almost all patients who had proteinuria in pregnancy, and they found almost 60% of these women had preeclampsia as the cause for proteinuria. They could be the underlying glomerular disease, it could be diabetes which has precipitated and they have underlying glomerular disease, and there could be non-renal causes of proteinuria as well. But then, if a female has proteinuria during the early part of pregnancy, is it just a variant of preeclampsia or is just a physiological alteration needs understanding? When we look into the terminology of biomarkers, they found that those biomarkers which were associated with preeclampsia had 1 to 2 weeks early onset as compared to proteinuria, suggesting that this gestational proteinuria could be just a mild variant of preeclampsia and might represent a subclinical preeclampsia. So goal of therapy is whether the proteinuria appears within 20 weeks or after is a point of concern. Well, does proteinuria in the nephrotic range happen in patients with preeclampsia? Well, there is a terminology called non-proteinuric preeclampsia. Way back in 2013, when the task force of hypertension came up in talking about proteinuria as one of the important causes and important sign and symptoms. But what happened, about 10 to 20% of women didn't show proteinuria in patients with preeclampsia and eclampsia. But then there are patients, almost 60% of patients when biopsied showed preeclampsia, and 1/3 of them had nephrotic range proteinuria. So then came the concept, does proteinuria matter in patients with preeclampsia? It is very important to understand is that proteinuria does play a role in patients with preeclampsia, but the degree of proteinuria actually doesn't correlate well to the outcomes. Whatever outcomes we came to see in these patients were not because of the presence of proteinuria or degree of proteinuria. The surveillance was much more vigilant in patients who had heavy proteinuria, and therefore these women were under surveillance, they were admitted, and therefore their fetal outcomes, what we call as prematurity, was not because of proteinuria, but the greater surveillance in them. So how do you evaluate patients with proteinuria in pregnancy? A good history is important. Timing of proteinuria is important. Do we have extrarenal manifestations? Any other associated problem prior to the pregnancy needs to be understood. The blood pressures, the edema, urine output, and of course the biomarkers of proteinuria and other biomarkers for preeclampsia as well. By definition, proteinuria is defined as more than 300 milligram per dl of protein or 21st collection. There has been data to say that what do you do with urinary dripstick test? That is the common test which is available with women when they come to an obstetrician. That 1+ protein has a false positive predictive value of 78% to a 3+ protein in the urine to a predictive value of 1.3%. So what they suggest is if a urinary dipstick has a proteinuria more than 2+, is important to be followed up subsequently over a period of time. Even RCOG guidelines do actually advocate our principles, and therefore they talk about that 24 hours proteinuria may be cumbersome. Even a 12 hours collection of proteinuria, protein creatinine ratio has a sensitivity specificity of almost 99%. Urinary protein creatinine ratios have had a sensitivity of nearly about 80 to 90%. So what is the impact of this nephrotic range protein on maternal fetal outcomes? There has been data to suggest the degree of proteinuria, the renal failure, the renal insufficiency, the hypertension, all correlate with the poor outcomes. We have also to understand when there is a poor uteroplacental perfusion because of low oncotic pressures, is going to adversely affect the fetal outcomes in terms of lower growth, lower fetal outcomes, and polyhydramnios. So, for a better maternal and fetal outcomes, a preserved renal functions, minimal proteinuria, and no hypertension is mandated. So, what do you do with women who had proteinuria before they conceived? See, one thing we must understand, all childbearing age group women who've had underlying proteinuria before they conceived should be evaluated in totality. They should be looked for initial therapies which could be fertility preserving treatments. However, when therapies are not strong enough, we should be discussing on steps to protect the fertility. Now, what do you do and how do you manage them? See, all women who are thinking of conceiving should be looked for disease activity before they become pregnant. The degree of proteinuria, the hypertension, and renal failure needs to be advocated in them. Of course, those women who have gone into remission and have been in remission for a period of 6 months with the maintenance immunosuppression or off treatment can be advocated to have pregnancy. But what is important is optimization of treatment. See, before conception, one has to be very sure what drugs they are going to continue beyond pregnancy. Because during pregnancy, certain drugs are going to be injurious to fetal growth, and other drugs which can have an impact on fetal and maternal outcomes needs to be understood. The disease has to be in remission, no active disease. If there is an active disease, postpone the pregnancy. We must also understand when the disease cannot be controlled, risk of pregnancy should not be advocated. Well, the drugs which are most commonly given in women with proteinuria is ACE inhibitors. There is a lot of debate what to do. Suppose a female conceives and she is on ACE inhibitors. There is data to suggest that within the first trimester of pregnancy, even if she continues to be on ACE inhibitors, she can be withheld with the ACE inhibitors once she conceives. Usually they advocate that one should hold on the ACE inhibitors 6 weeks prior to the conception, but if she is on the drug, she can withhold in the first trimester of pregnancy. The azathioprine, tacrolimus, cyclosporine, and hydroxychloroquine are safe enough to be given in pregnancy. Rituximab steroids needs consideration risk to benefit ratio, and when these patients are at risk to preeclampsia. We tend to use them with low dose aspirin as well. What do you do with thromboprophylaxis in women? Those women who had proteinuria of more than 250 milligrams per millimole or hypoalbuminemia, they are always at risk to thrombotic tendency because pregnancy per se is a prothrombotic state. So there is an education to give heparin, low molecular, even conventional heparin in these patients. How do you follow them up? A multidisciplinary approach is essential. One has to have regular follow-up of blood pressures, urinary protein, creatinine. We should look for flares. We should look for relapses. We should look for drugs which can be safely be given in pregnancy and also help in distinction between the primary disease which has relapsed or a preeclampsia which needs understanding. What do you do when the nephrotic syndrome happens during pregnancy? Conventionally speaking, outside pregnancy, proteinuria, hypoalbuminemia, edema, hypercholesterolemia, lipiduria is common to happen. But what happens in pregnancy? You see, in normal pregnancy itself, the albumin decreases. It is the globulins which rise. There is a tendency of insulin insensitivity to happen, so the cholesterol, the lipids tend to rise. So how do you differentiate here that this lady is going to be having nephrotic syndrome? So one has to be cautious and alert. One has to look in the high risk population, especially diabetic or hypertensive. The proteinuria has to be quantified and evaluated and followed up. Well, do we biopsy them? There are pros and cons towards biopsying this patient in pregnancy with proteinuria. They say that those diseases which are rapidly progressing, disease where the proteinuria is aggressively progressing, whether we should biopsy them or not. There is data to say that risks of complications are higher when we tend to biopsy them beyond 23 weeks of pregnancy. Before 20 weeks, well, it is safe enough to do it. 20 to 22, 3 weeks, one says we may or may not do. Beyond 23 weeks, there is data when it's going to make a histological, severity of the disease may make a change, then probably we might have to biopsy them. What are the risks involved? See, we must understand the bleeding is one of the major concerns with patients who are having nephrotic syndrome in pregnancy, and we think of biopsying them. See, what is happening as beautifully described in the first lecture we had today morning, there is going to be increased plasma volume. There is hyperfiltration happening in the kidneys are bulky, inflamed, and if you biopsy them, what will happen? They can tend to bleed, they may have perirenal hematomas, they are known to have perinephric hematomas, and sometimes these bleedings can be torrential, and sometimes they can even present with precipitation of child having premature death and even fetal death as well. So what is important? The bleeding risks, the risk of difficulty in biopsying them. See what is happening. The gravid uterus is growing up. How do you do a conventional biopsy in these patients? You can't make the lady go prone. So you do it in a lateral position or you make her sit. It's so difficult doing even with the ultrasound guidance, it's so bloody difficult to do all this. So what we must understand is that one has to weigh the risks and benefits. So where do you think we should biopsy them? Those are patients where there's worsening of renal failure. Lupus, well, active disease, you're seeing that progression, there's rapid progression, or disease where there is no serological markers. And of course, when we looked into the data when biopsy was done, it was resulted in therapeutic change in 66%. But who were those patients? Those patients were where there was hardcore indication of biopsying them. So one needs to be calculative while biopsying these patients, because empirical therapies also have its own risks. There's always a risk of hyperglycemia, worsening of hypertension, and infections as well. But now comes a problem. What happens when the proteinuria happens beyond 20 weeks? Before 20 weeks, you may have proteinuria, whether that proteinuria is gestational proteinuria that is going to go into preeclampsia, or whether this proteinuria is as well as glomerular disease needs to be understood. We need to follow them up. What happens if it happens beyond 20 weeks of gestation? Well, preeclampsia is one condition which manifests, so you have clinical evidence of the ratios, which if a ratio of less than 38, you rule out a possibility of preeclampsia and look into specific diseases. Like membranous is very common to happen. So if PLA2R and other biomarkers are available, we are not required to biopsy this patient. Vasculitis, even lupus, there are markers which can tell you that these probably may not be a preeclampsia happening to them. So, as one of the students asked, how do you differentiate a patient with lupus flare to a preeclampsia? See, lupus, as discussed earlier, complements are on the higher side during pregnancy. The lowering of complements, increased dsDNAs, active sediments, low uric acid. What will happen in preeclampsia? The uric acid tends to rise. Here the uric acid is going down. So therefore, these patients needs to understand that this is a lupus flare rather than preeclampsia happening, because the treatment is entirely different. Here you might have to give methylprednisolone, you might have upgrade and add on tacrolimus in them. However, in preeclampsia, you probably will have to optimize the blood pressures. So there are challenges in terms of what drugs to give, what drugs not to give in pregnancy, and the management of the issues holds so true as well. If you look at the degree of proteinuria, if the proteinuria is less than 3.3, so you just monitor them up. If it's been 0.3 to 3 grams, so you need to very frequently keep on checking them within 24 hours, within a week's time, you keep on monitoring them. And more than 3 grams, one has to be very cautious while observing. So what are the problems which we tend to face in them? Edema is a very big problem. You know, pregnancy per se, there is going to be edema, and because of the salt and water retention and the interstitial fluid leak, they tend to have a lot of edema in them. This can be a source of infection. It could also result in risk of leakage and complications during the cesarean section. So what do? You advocate raising stockings, leg elevation, which can increase the venous return, salt and water restriction, and there is data what to do with diuretics. See, what is going to happen with diuretics, the intravascular dehydration, hypotension can happen. There is data coming up which says diuretics can be tried cautiously while dealing with these pregnancies. What do you do with albumin? In our data, we are going to just show, we tried using albumin a few of these patients. The albumin, as the obstetrician would believe, there was so much of talk about using of albumins in patients who were on spinal anesthesias and patients with toxemia of pregnancy, where they did use albumin in them and they didn't have any complications. So as of date, the data definitely doesn't say no to them, but there is no, one has to be skeptical while using these drugs. Blood pressures, variable. They may have high blood pressures, they can have low blood pressures. So one has to optimize the blood pressures in them, restrict salt and water. If drugs need to be advocated, try using drugs which are safer in pregnancy. Drugs which can be safely given are the drugs like the labetalol and the nifedipines. Disease can progress well. IgA, membranous, they have been seen to progress in pregnancy, and there in that condition, one has to be very careful in optimizing and modifying their immunosuppression them. What happens with the acute kidney injury? Almost in our data, almost 30% of the patients developed acute kidney injury, and this was because of the low intravascular oncotic pressure. One has to be also skeptical. One has to look into whether are we dealing with some chronic kidney disease in them. We need to monitor the salt and water, carefully manage the preeclampsia or acute kidney injury, which could be because of any drug or because of hypovolemia. One has to be careful in them. As already said, thrombotic tendencies are much more higher in these women. Classically, they tend to have lower limb edema and pain. In extension beyond that, they are always at risk to pulmonary embolism. So when their patients have a higher propensity to develop thrombotic tendencies and having low albumins for a long period of time, we could probably use the anticoagulants in this group of patients. As in our patient, when the present patient had anemia to begin with, she had a hemoglobin of 8.6. So what were the possible reasons to have anemia in them? The reason for anemia could be innumerable. They could be poor gut absorption. There's so much of edema, intestinal edema. There is going to be hemodilution, which is going to happen because of increased plasma volume, and there are other factors as well, because the transferrin is lost and all other proteins are lost in the urine. So all contribute to anemia. So one has to restore the iron status, and of course, if need be, if a patient is CKD, she may require erythropoietin as well. Nutrition wise, these women are hypoalbumic. As we already said, there is data to say that women who have hypoalbuminemia during pregnancy, irrespective of underlying nephrotic syndrome, she is liable to have tendency to have complications during her term. And therefore, one has to be very cautious and maintain the nutritional status. Vitamin supplementations may require to be given to these women because of the poor absorption from the gut. Well, there is always a possibility of loss of urinary gamma globulins, and we would possibly think that they are increased risk to infections. But when we looked into literature, these women were not having increased tendency to infections, and therefore there is no role of prophylactic antibiotics in them. But one may consider adding antibiotics in those conditions when you have a higher immunosuppressants being given to these women. So what do you do short of biopsy? You haven't biopsied this woman. You still want to treat her when the edema is worsening, her proteinuria is worsening. What do you do with those women? What is the role of steroids? Steroids being the very good therapeutic implications in a large majority of the nephrotic syndromes. And there have been valid role of them because the steroids are inactivated by the placental alpha-beta hydroxy dehydrogenase, and therefore they do not cross the fetal barrier, and therefore is safe to be given in pregnancy. What about CNIs? CNIs are also considered safe, though they cross the placental barrier by 70%. But what is happening interestingly is that the P-glycoprotein, which is present in the placenta, actually sends back the cyclosporin and the CNIs, and therefore it is considered to be safe in pregnancy. The other drugs, azathioprine is safe in pregnancy, MMF and SIF no. What happens is, suppose patient has a flare or has a disease which suddenly happened. What do you do with the immunization? Lupus, there is a flare. Now you gave methylprednisolone, it didn't work. What do you do next? Here is the role. Suppose she is in the second or the third trimester. There is some data to say that we could advocate using MMF in those conditions. Suppose she has a flare. Now she's in the first trimester of pregnancy. There is some data to say that rituximab is safer in the first trimester because by 12 to 22 weeks there is increased transmission of the immunoglobulins through the placenta, and therefore they lead to complications. Delivery, well, it doesn't, the proteinuria is no indication for doing a cesarean section in them, but yes, worsening fetal outcomes, preeclampsia, does propagate them to go for an early management. Postpartum, breastfeeding is encouraged. It's safe to give all the drugs like azathioprine, tacrolimus is safe in the pregnancy. And if suppose we haven't biopsy this patient, 6 weeks postpartum, you can advocate a biopsy in them. One has to be cautious to look for dehydration, because once the delivery happens, the intravascular volume depletes, and one may always have a risk of dehydration in this population. This is our data. When we had our own data, we had 18 patients, 18 pregnancies where we didn't biopsy these patients because they presented quite late, 23 weeks of pregnancy. Of them, 5 had worsening hypertension and 3 had preeclampsia. Of them, there was worsening anasaka in 6 of them, and we had to admit all of them. In majority of them, just conservative approach. 2 of the patients we had to give albumins, and unfortunately we had more of IAGRs and preterm, but all the children did well after they were managed subsequently. We biopsied a majority of them. We did give immunosuppression. I wanted to highlight, I forgot to tell you that we did give immunosuppression in 3 of our patients. 2 patients, we retrospectively when we biopsied them, had FSGS. 1 of them we gave steroids. This lady did respond to steroid, and there was a decrease in proteinuria. The other lady didn't respond at all. It was so bad for her that we admitted her. We gave her conservative management, and she was admitted till the term, and we gave her CNI. That was the first time we used CNI in them, and she showed significant improvement in her proteinuria. And the other lady where we used CNI with steroids was one which was subsequently biopsied to show have membranous nephropathy. So a careful distinction between the etiology of proteinuria in pregnancy needs to be understood. Biopsy may or may not be required depending on the etiology and the risks to complications. Such pregnancy needs detailed counseling, because some women are going to become pregnant if they have a proteinuric illness in the past. A preconceptual counseling is must in them. Though the outcomes are good, but yet the risk for maternal fetal or complications need to be explained, especially patients who have renal failure and hypertension. But then multidisciplinary approach is the need of the hour, and I rightly want to end up with saying that clinician presentation may be full of dilemmas and challenges. a true clinician is one who uses his wisdom and expertise and timely manages them. Thank you so much.
An excellent presentation, madam. It was a delight to listen to you. Could you please tell us again, when do you give IV albumin to which category of patients?
So the problem, when we first thought of giving albumin in these women, there was so much of data which was talking, one group of patients was saying no albumin, the other was saying we could try using, because when I looked into the literature, because that was a time when, what do we do with these women? There was so much of anasaka, she used to have the moment you give her diuretic, she used to get some rise of creatinine. So what do we do? So what we decided with those women, that we gave albumin with diuretics, and did she responded. She was at third trimester of pregnancy, she had this edema. But then when I looked into the literature, as madam would rightly say, in toxemia of pregnancy, way back in 1970s, they tried using these albumins in managing this pregnancy with toxemia. So there I thought, if that time it is safer, so why not try in these women as well?
Thank you, madam. That was such an excellent presentation, comprehensive talk on this. Let's discuss topic actually. When I was asked to chair a person by Sri sir, I was wondering I don't have much experience in this particular topic, and you are the right person to discuss, because there are only two papers, original papers, and madam authors one of those papers. Both are retrospective analysis of data, their center experience. The problem when the patient is having already known nephrotic syndrome, FSGS or lupus nephritis, known nephrotic syndrome getting pregnancy, we have some clue, madam. Currently, we have a patient, 24 weeks gestation, nephrotic range of proteinuria, worsening proteinuria from 18 weeks of gestation, worsened to 10 grams per day. And she was not willing for biopsy, conceived through assisted reproductive technique. And complements were normal, and plateau receptor antibody levels were normal. Currently, the patient is on nifedipine, labetalol, and aspirin, and with the furosemide. There is no biopsy diagnosis. Biopsy she is not willing. Even if she is willing, as you rightly said, whether prone position or left lateral position or sitting position, it's very difficult. So how do you manage some patients with steroids? So what are the indications where you would prescribe steroids?
See, what happened in our patients, we tried steroids in 3 patients. Of the 18 patients, all of them we managed conservatively. Of the 3 patients where we started steroids, the proteinuria was worsening, the edema was worsening, and the hypertension was worsening. So we thought, what else? The most possible diagnosis could be either FSGS, and it could be either membranous in that region. So we thought of giving steroids and see. One of the ladies, the one I had a problem was when we got her admitted, she had gross anasaka, gave her albumins and all. There we gave her CNI as well. The other 2 ladies, we gave CNI.
What was the timing of therapy, madam? Timing of therapy and the response?
All the 3 patients had it in the 2nd trimester, but the worsening of proteinuria hypertension happened in the 3rd trimester. I was just wanting to bring in another important thing. So recently, when we were seeing patients in the OPD, there 2 situations happened to us. One lady, she came to us in around 2nd trimester of pregnancy. She had proteinuria. She didn't have hypertension at the time of presentation, but she gave some history that when she was young, she had some proteinuric illness, and then so we presumably thought that she had, we thought of biopsying her. She was not willing for biopsy, so we just followed her up. She had the edema worsening, the albumins were dropping, but because it was safer to manage her till the end, and we did not give her ProTab, and fetal outcomes was good. So when I always keep telling when we see the patients in the OPD, what is interesting to see is there is another lady who came to me. She was just 12.5 weeks of gestation. She had edema. She had worsening hypertension. But what was happening to her was she had a fetus who had IUGR. See, when a patient who has IUGR happening in the very first trimester of pregnancy with proteinuria and hypertension is appearing, it could be very well be preeclampsia, the early onset preeclampsia, which we say 12 to 13 weeks of pregnancy, the early onset preeclampsia can manifest. So gestational proteinuria should not be left unwanted. One has to follow them up properly, and we have to see them, because whenever a patient comes, usually if the patient's hypertension, there is no renal failure, these pregnancies will quietly be safe to take it to term. But if they are happening it early, and then the one has to be cautious about preeclampsia.
Thank you so much, ma'am. I think it was an excellent to hear to you after our DM days from our dear teacher. My question is that we have a problem when the patient gets admitted to the ward. For example, for a normal nephrotic syndrome patient, when they get admitted to the ward, we have a sense of direction. We measure the weight of the patient, we give diuretics, we do daily charting of the weight, and we target a weight of 0.8 to 1 kilogram weight loss over a period of time as per the diuretic. As far as a pregnant lady, when they get admitted, we go to no man's land. First of all, we are hesitant to start diuretics. With a lot of gathered courage, we start diuretics. We monitor input output. How do you monitor the patient on a daily basis after you start diuretics to give a targeted weight loss or to deserve a eulemic state?
You are absolutely right. Women with proteinuria and edema, monitoring them is very difficult, because you see, more you give the diuretics, the more risk of complications, more hyponatremia, more stuff, more edema, more vasodilatation. There's going to be more oncotic constriction, and the patient's going to have AKI. What I'm trying to say, there was that lady which I was telling you, 3 of our females developed AKI, because probably our understanding evolved over time. So when we gave a bit of diuretics, they had small rise of creatinine. It was not much, but there was a rise of creatinine. So one has to be cautious while monitoring these patients, how much you need to bring her weight down, because you can't get the weight down also, because the edema is so much, you have to monitor her nutritional status. So all those challenges are there while managing these women. It's not easy.
Any questions from the audience? Thank you, madam.
Thank you, Dr. Anupama, for the wonderful presentation. We request the chairperson to hand over the memento to the speaker. We request Dr. Sabarinath to present the mementos to our chairpersons.
Thank you, sirs and ma'ams. Coming to the next session on managing pregnancy in a patient with lupus nephritis. We welcome the chairpersons, Dr. Srijit Parameswaran, Professor and Head of Nephrology at Jipmer, Dr. Vijay Shankar, Assistant Professor NMCH and Consultant at Rubin Memorial Hospital, Pune, and Dr. Shubhashree, Consultant Nephrologist at Prashant Hospital, Chennai.
We introduce our esteemed speaker for the session, Dr. Tina Zakaria, Assistant Professor Nephrology, Columbia University, New York. Dr. Tina is a graduate of Albany Medical College, New York, and a nephrology fellow from Columbia University, with special interests in the fields of glomerular diseases and obstetric nephrology.
We have a recorded lecture, so we'll listen to that. After that, we will discuss.
In terms of her lupus background, she was diagnosed renal biopsy was consistent with cause for lupus nephritis. At that time, she was treated with cyclophosphamide, prednisolone, and hydroxychloroquine, and she was maintained on mycophenolate. She achieved a partial renal remission with 1+ microalbumin of dipstick, return of C3 and C14 normal levels, and an anti-DSD antibody that repeated at that time. Now let's fast forward to 2021, where MMF is being changed to azathioprine because she's planning to conceive. She has persistent 1+ albumin monocytic. Later on, it's not clear exactly when she got pregnant. She presents to at the hospital with worsening proteinuria. Her urine protein to creatinine ratio is 2.89. Her complements are low. Her anti-DSD antibody is positive. Her antiviral antibody is positive. Antiphospholipid antibody is negative. She's diagnosed with lupus flare, transferred to Jipmer Hospital for further care. Maternal and fetal risks were discussed, and she desired to continue the pregnancy. So today we'll be going over pregnancy planning in lupus nephritis, management of it during pregnancy, the impact of lupus nephritis on outcomes, and other considerations. So let's pretend it's back in 2021, and this patient comes to your office while on mycophenolate with the 1+ microalbumin in the urine, and asks, "Doctor, I'd like to get pregnant. What are the steps I need to take to ensure safe pregnancy?" So our responsibilities as the provider is to counsel on maternal and fetal risks, counsel maternal and fetal outcomes, and manage lupus medications that are compatible with pregnancy. Throughout the presentation, you'll see a little blue star that should make you think about the case. So you'll see throughout the slides. Lupus in general often occurs in women of childbearing age, and they have higher maternal and fetal risk. They're able to recognize lupus earlier now, which makes family planning even more important. Lupus itself does not seem to affect fertility, however, the treatments do. Cyclophosphamide can cause premature ovarian failure, steroids can cause metabolic syndrome, it affects the hypothalamic pituitary ovarian axis, leading to inauguration in some, and the NSAIDs, which inhibit prostaglandins, can prevent oocyte release and cause transient infertility. Antiphospholipid syndrome is a complication that we see of lupus, and basically these antibodies cause damage to blood vessels and increase the risk of clotting. They can present with thromboses, strokes, and miscarriage. Pre-pregnancy counseling requires a multidisciplinary team, including the obstetrics team, MFM specialists if you have it, nephrology, pediatrics, and sometimes cardiology. The first step of counseling patients is they need to understand their risks. So risk factors associated with adverse outcomes during pregnancy include active or flaring lupus, although most of these still result in live births, active nephritis or prior nephritis, positive serologies, anti-DSD antibody, and the APLs, hypertension, glucocorticoids. They're requiring more than 20 milligrams per day of prednisone. That puts them in a high-risk category. And the discontinuation of hydroxychloroquine is also associated with increased risk of lupus exacerbations during pregnancy. We need to also look at some labs to also help assess the risk. These include antiviral and lab, understanding what their baseline kidney function is, do they have proteinuria or urine sediment, their CBC, liver function tests, their serologies, and their antiphospholipid antibodies. Understand that without symptoms of antiphospholipid syndrome, it's unclear how to always interpret the antiphospholipid antibodies, but it's always useful to check. So lupus, anticoagulant, anticardiolipin, anti-beta-2 glycoprotein. This is a very comprehensive checklist. This is a great review if you have a chance to read it. And this is something that you should go through with each lupus patient before they get pregnant. So if they've had any flares in the past 6 to 12 months, lupus nephritis, which our patient has, serologies, everything that we just discussed, antiviral and law. In addition to these things, we have to look at general risk factors such as maternal age, hypertension, diabetes, obesity, etc. In terms of risks of patients with lupus with or without antiphospholipid syndrome, so whether they have lupus with or without, they are at higher risk of prematurity, preeclampsia, and health. And this is where our patient falls. And if someone has antiphospholipid syndrome, despite this being primary versus secondary to lupus, they have a slightly higher risk of all of these three things. Active lupus nephritis is associated with higher rates of maternal and fetal complications, including low birth weight, pregnancy-induced hypertension, high risk of flares, especially lupus nephritis flares. And women with lupus nephritis remission have less rates of preeclampsia, preterm birth, pregnancy loss compared to those with active lupus nephritis. Lupus patients with a renal transplant have similar outcomes to other transplant recipients with pregnancy. Ideally, in a patient with lupus nephritis, we want their lupus nephritis to be inactive for at least 6 months. So what does that mean? Remission means normal kidney function, urine protein to creatinine less than 0.5, inactive urine sediment. If they already have a reduced GFR due to chronic kidney disease, we want to counsel them on the risk of worsening renal failure during and after pregnancy. Reviewing their other comorbidities is also important, like we discussed before, hypertension, stroke, pulmonary hypertension, heart disease. And then in terms of medications, it's very important to counsel them that they should not just stop their medicines without talking to you. Complete discontinuation of lupus meds increases the risk of lupus flare and pregnancy complications. So treatment has to be tailored to individual cases. However, most patients should continue hydroxychloroquine and take a low baby aspirin, 81 milligrams, unless contraindicated. And this is usually started at 12 weeks gestation and onwards. This is based on the USPS task force because lupus patients in general are at higher risk of preeclampsia. So that's why aspirin is recommended. These are the medicines that are acceptable in pregnancy: azathioprine, calcineurin inhibitors, hydroxychloroquine, and glucocorticoids. In terms of the calcineurin inhibitors, you need to be careful because the pharmacokinetics change. So their levels can drastically drop, especially in the first trimester. So in that first trimester, you should be expecting to have to increase that tacrolimus dose by quite a bit. And for glucocorticoids, the goal is to be on prednisone less than 20 milligrams a day. These are the medications that we want to avoid in pregnancy: cyclophosphamide, leflunomide, methotrexate, mycophenolate, and rituximab, belimumab, and nivolumab. These can cause neonatal B cell depletion, and the other drugs are all teratogenic. So back to our patient. So she's asking us, what do I need to do to prepare for this pregnancy, and what are my risks? So the way I would counsel this patient is, due to your lupus and history of lupus nephritis, you are at higher risk of adverse pregnancy and fetal outcomes. Due to your positive anti-growth, the fetus has a higher risk of neonatal lupus and congenital heart block. You need to stop your mycophenolate and start azathioprine, and the goal is for your lupus nephritis to be stable for 6 months prior to conceiving. By week 12, we want to start a low-dose aspirin, and your antiphospholipid is negative, so there's no need for low molecular weight heparin based on current labs, and you will need close monitoring for yourself and the fetus during the pregnancy. Now, in terms of management of lupus, we'll talk about monitoring, identifying a lupus flare, and how to treat a lupus flare. So the initial labs we already discussed. So we have to assess their baseline renal function, proteinuria, their CDC, liver tests, anti-viral, anti-raw. So our patient, we have that she has some protein in her urine, she has positive anti-viral, negative antiphospholipid antibodies, and at the start, at least as far as we know, her complements were better when she was on the MMF. And then integral labs that are needed are the following: CBC, serum creatinine, urinalysis, and serologies. The serologies are important because they can help differentiate between a lupus flare versus preeclampsia later in pregnancy. And a monitoring schedule is not really, there's no specific protocol saying how often you need to see these patients, but obviously they're high risk, so see them more frequently. And use the local protocols for high-risk pregnancies, similar to what we use for those with hypertensive disorders and placental insufficiency. In terms of fetal monitoring, so umbilical and uterine artery Doppler sonography is recommended at 20 to 24 weeks. It has a good negative predictive value for preeclampsia or intrauterine growth restriction. And then for fetal echoes, this is recommended if there's a higher risk of fetal dysrhythmia or myocarditis, and same with complete heart block. So our patient has a positive anti-Ro. So if they have positive anti-Ro or law, we recommend fetal echo. In addition to that, if a patient has had a previous pregnancy where their child was affected by a complete heart block, they are at higher risk of this happening again in the subsequent pregnancy. So they should be getting a fetal echo weekly after 16 weeks of gestation. It's not clear how cost-effective this is in women who don't have a history of this, but it carries no risk. So if it's possible, it's recommended. Identifying a lupus flare in pregnancy can be tricky because a lot of symptoms in lupus can sometimes be physiological changes in pregnancy. So for example, skin lesions and rashes in pregnancy, they can have melasma, which is also a skin change. They can have hair loss due to decrease in estrogen levels during pregnancy, and they can also have arthralgias in pregnancy. Due to the ligaments loosening, they can also get joint aseptic articular hydrops. If it's involving more than 2 joints, you want to think that it's probably more lupus rather than just normal pregnancy changes. And in terms of proteinuria, it can be due to lupus, pregnancy-related, or due to underlying renal disease. So in a lupus flare, this is often accompanied by extrarenal signs, skin changes, joint pain, increased DSD antibody. And in these lupus patients, the proteinuria is usually gradually increasing. They also have hematuria, microscopic hematuria, before the 20th week. You can consider a renal biopsy to help differentiate, but this is higher risk. In preeclampsia, this usually occurs after the 20th week of gestation, resolves after delivery. Hypertension is associated with proteinuria, headaches, thrombocytopenia, and elevated liver enzymes. And this is also a nice table going over the different parameters and what you expect in preeclampsia versus lupus. Other labs to keep note of. In lupus, you can see an elevated ESR. However, this can also be in a normal pregnancy as well. So that can't be the only reason you think someone has lupus. Thrombocytopenia can also occur in 8% of normal pregnancies. If it's severe thrombocytopenia, you want to consider ITP or other diagnoses. Leukopenia, which would point towards lupus, can be masked in pregnancy because in pregnancy there's increased leukocytes, but it's usually neutrophils. So you can sometimes use lymphopenia as a marker for lupus instead. In terms of low complements, it's important to get baseline complements before pregnancy because during pregnancy, there can be up to 10 to 50% increase in C3, C4, CH50 during pregnancy. So you may not be able to realize that their complements are lower if you don't have a baseline. Possibly you can use C3A levels instead to detect lupus flare. There's also an increased estrogen-related synthesis of proteins in the liver, so the factors involved with coagulation. There are different scales to help standardize the assessment of lupus activity during pregnancy. The 2 that are validated are these 2, excuse me, the LAIP and the Modified Physician Global Assessment. The Systemic Lupus Activity Index or SLEPDI is also being used frequently, but based on research, these are the 2 that are validated. These are just scores that use these parameters: fever, erythema, arthritis, organ involvement with the lupus, the medications they're taking, and labs. And then in terms of lupus treatment in pregnancy, again, it really depends on the patient, the severity of disease, organ involvement, but in general, if someone has stable lupus nephritis, they should be on hydroxychloroquine, azathioprine as first line. Otherwise, some are on CNI or tacrolimus, cyclosporin. Prednisone, again, we want the lowest dose possible, and low-dose aspirin after week 12. Now, in terms of a flare, which can be the more difficult part, all patients should be on hydroxychloroquine, and the #1 choice for the treatment of a lupus flare is methylprednisolone, a pulse, followed by prednisone, which is tapered throughout the pregnancy. And then if they're not on azathioprine already, you need to start it. If they're already on it, you might need to increase it. tacrolimus can also be added as well. In very severe cases, if it's life-threatening, cyclophosphamide and rituximab are used, but this is life-threatening. This is very high risk for the fetus. In terms of steroid dosing when treating lupus, so this is based on the KDIGO guidelines. This is the high dose scheme, moderate, and reduced dose. So you could probably try to use between reduced dose and moderate and follow the prednisone taper that way during the pregnancy. It depends on how they're doing, if they're improving with the steroids. Now back to our patient. So she is here with worsening proteinuria. Is this a lupus flare? I would think so. She's presenting less than 28th week of gestation. This is not consistent with preeclampsia, and if she has low complement, her dsDNA is positive. So in terms of how would we treat this patient, we would continue azathioprine, assuming that she was taking it. Hydroxychloroquine, would recommend a mini pulse with the steroids, and by mini pulse I mean using the smaller dose of the methylprednisolone for 3 days, followed by prednisone, and I would also add tacrolimus. At Columbia here, we would continue this triple therapy throughout the pregnancy as long as that they can tolerate it. Sometimes the tacrolimus might be limited depending on their kidney function. If they have worsening kidney function, they will not tolerate tacrolimus. But for most patients, we try to use all three if they're having a severe flare. Lovenox is also recommended if they're hypoalbuminemic, aspirin, and then because she's anti-positive, we recommend fetal alcohol. Pregnancy planning and lupus nephritis we went over, management during pregnancy, and now lupus nephritis impact on the maternal, fetal, and renal outcomes. So lupus nephritis generally has worse outcomes. It is not surprising. There are several studies that have been done. Most of them are smaller studies, but this is the nature of any field dealing with pregnant patients. So Gladman did a study showing that there tends to be higher rate of low birth weight in pregnancies in mothers with renal disease. Saavedra did a study with 95 pregnancies and all with lupus, which I'll be talking about in detail next. This was a retrospective study done by Wagner and their team. They showed lower rates of preeclampsia, preterm birth, pregnancy loss, and women with lupus nephritis remission compared to those with active lupus nephritis. And the PROMISE study, which was done in 2015, looked at pregnant patients with inactive or stable mild, moderate lupus, and severe flares were less frequent, and risk factors, they looked at the risk factors associated with adverse pregnancy outcomes. So this is the study that I just mentioned previously, Saavedra et al. So looking at maternal and renal outcomes. So women with renal flares were maintained on high-dose steroids and had live births. And in general, their renal function was generally preserved. If you look at their serum creatinine in patients who had renal disease versus those who did not, their kidney function was preserved despite having a flare during pregnancy. And in terms of fetal outcomes, in this particular study, there was no difference in the rates of fetal complications in lupus patients with and without prior lupus nephritis. However, preterm birth was the most common adverse pregnancy outcome. The rate of live births was similar in both groups, and they did not find a difference in the mean fetal weight. A lot of these studies have different results depending on, because the studies are so small. But it's hopeful for lupus patients that they can have a pregnancy with a live birth, stable kidney function, and not too many adverse pregnancy outcomes. But they are at higher risk if they have active lupus nephritis. In general, this is lupus's impact on maternal fetal renal outcomes. So this was the PROMISE study, and they basically looked at a bunch of, they looked at over 300 lupus patients. And they defined the lupus flare based on that SLEPDI score, physician global assessment score, hospitalizations, new worsening disease. One thing to take note of was for inclusion criteria, the urine protein to creatinine ratio had to be less than 0.5 grams, and this was in 91% of the enrolled patients. Patients were excluded in this study if they had a urine protein creatinine ratio greater than 1 gram, creatinine greater than 1.2, or hypertension or urine sediment. So these are not even including patients with proteinuria and elevated creatinine, and look at how much more the adverse outcomes were compared to stable patients. So pregnancy's effect on lupus, 26 to 38% of patients have a lupus flare during pregnancy, even if they were previously controlled for about 6 months before that. And lupus patients with high disease activity in the first trimester had a much lower chance of live birth or full-term birth compared to those with low activity. And they had a lower chance of a full-term pregnancy. Now, other considerations to think about with dealing with lupus patients. So, managing an unplanned pregnancy in lupus, this can be very stressful for the patient, so it's important for us to have a stepwise plan. And this is based on the American College of Rheumatology guidelines. So immediately you need to stop the teratogenic medications, start a prenatal vitamin. If the patient was on methotrexate, you want to add folic acid 5 milligrams daily. They also recommend if the patient was on leflunomide to start cholestyramine washout 8 grams 3 times daily for 11 days. You need to estimate the exposure time to the teratogenic meds, so understanding when was their last menstrual period, and conception is usually about 2 weeks after that. We want to assess their lupus activity immediately. Lupus labs, clinical signs of active lupus, determine if they've had lupus activity over the prior 6 months, use of prednisone dosing. And you want to treat them with hydroxychloroquine, aspirin if they're more than 12 weeks in their pregnancy. And if they were on any of the teratogenic meds, we need to consider azathioprine as first line. And they may need tacrolimus or cyclosporin on top of that with prednisone, especially if they have active lupus nephritis. Now, special considerations for antiphospholipid antibody positive patients, which our patient was not. So if it's positive, this is associated with significantly higher risk of pregnancy, morbidity, and loss. There's an increased risk of preeclampsia, intrauterine growth restriction, placental insufficiency, and preterm delivery. APL present in about 25 to 50% of lupus patients, but only a small percent develop antiphospholipid syndrome. So this is when we see persistently high APL titers, 12 weeks apart, thromboses. Asymptomatic women also have higher rates of pregnancy loss. And the management is based on the risk profile of each pregnancy, and there's limited evidence. But for asymptomatic women with positive APL with no prior events, we recommend at least a low-dose aspirin. If they have positive APL with recurrent early loss or more late fetal loss, but no history of thrombosis, even though they don't quite fit the antiphospholipid syndrome diagnosis, this is considered obstetric antiphospholipid syndrome. So in this situation, it's recommended to give aspirin and low molecular weight heparin. In some cases, they need unfractionated heparin, and this definitely needs to be the case 6 weeks prior to delivery, and they continue heparin 6 weeks postpartum. Positive APL with history of prior systemic thrombosis with full therapeutic doses of heparin throughout the pregnancy. And those refractory to aspirin or heparin with recurrent losses can consider steroids or plasmapheresis, although this is only with case reports and the data is very limited. Most patients with a positive APL in the first trimester without clinical criteria for antiphospholipid syndrome remain in the high positive range throughout the pregnancies. But it's still useful to check these values. And the APL can decrease during pregnancy, but it's not associated with the outcomes. And a positive APL without clinical symptoms of antiphospholipid syndrome is not necessarily associated with pregnancy morbidity. In summary, lupus and lupus nephritis patients, ideally, we want them to be in remission for 6 months on medicines compatible with pregnancy. We have to assess the risk factors in the patient, especially with lupus nephritis and other severe comorbidities. Getting initial serologies can potentially help differentiate lupus flare versus preeclampsia later in pregnancy. Patients with mild to moderate lupus who develop lupus flare generally do well in terms of maternal fetal and renal outcomes. So despite the fears that providers may have, if they have pretty well-controlled lupus or lupus nephritis, they generally can do well. And a multidisciplinary team is needed to care for these patients. This is a nice summary from KI reports. So basically, kidney care in lupus, expect the unexpected. So higher risk of flares, hypertension, preeclampsia. For fetal, higher risk of premature delivery, intrauterine growth restriction, looking for antiphospholipid antibody syndrome. And in terms of immunosuppression, remember hydroxychloroquine, azathioprine, CNIs, prednisone less than 20. If there's a flare, we want to do steroids. And then increase or add azathioprine, and sometimes we do triple therapy with tacrolimus, and we usually avoid cyclophosphamide or rituximab. I want to give a special thank you for inviting me to this talk. And Dr. Peripartum was the one who emailed me, so thank you, and hope to meet you all one day. And I'd like to thank Dr. Radhakrishnan and Dr. Bombach, who also mentor me and are my permanent teachers. If you have any questions, please feel free to email me. This is my email here. And I look forward to speaking with you. Thank you.
Actually, if you have been listening, I don't know how good was the audio. She has addressed most of the issues we wanted her to highlight, including preparing a patient for pregnancy, monitoring during pregnancy, modification of these other specific issues we thought were relevant to our practical management. So there was one thing I think she didn't address in her lecture, that is most of these patients are likely to be on ACE inhibitors or IRB, but if you look at the medication, she didn't mention what to do if the patients are already on, or you have a patient who has come to you with pregnancy and the patient is on ACE inhibitors or IRB. So any views from the audience on that? What should we do?
I think Dr. Anupama had mentioned in a talk that it should be stopped as early as possible, not later than 6 weeks after conception.
I was expecting one of the students to respond, but we have told the right thing, that it's not that the point. Again, I think what needs emphasis is that just because somebody was on ACE inhibitor or IRB, when they are diagnosed to be pregnant, they did not be terminated, because they are known to be teratogenic, but then that incidence is very low, and renal failure and all happens if the exposure is later in the pregnancy. So usually this is not very rare. CKD patients also, we do get people who get pregnant and come to us while on ACE inhibitor IRB. We don't terminate them. What we do is to immediately stop the drug. Okay, that's one thing. The other point which she made in the which is not often discussed is, suppose there is a patient who comes with pregnancy with active lupus, say class 4 lupus nephritis. She did discuss it. I hope the message went through, because if you look at it, if you look at the list of drugs which are known to be effective, okay, there are a lot of drugs which we can use, but then proven effective treatment of say class 4 lupus nephritis, there are very few of them which are safe in pregnancy. So what remains is steroids, azathioprine and CNI. Right, so that is the regimen which she was also, which is practically used also, right? When you can't use MMF, even though you may think what is the data on treatment of these patients with these drugs, also diaprine and all, but then what is practical? Okay, you can say that you can encourage the patient to consider termination and treat the lupus and then consider treatment later on, which in our experience some of our patients are very adamant of not doing that. So then we have the option of treating with what is available, and I do believe that the best option we have is to treat with steroids plus azathioprine plus CNI. I would like to invite comments from Mike.
Thank you, Sri, sir, for having me here. I would like to have the opinion from either you or from the chair. Okay. Or yeah. Okay. So we do understand that we have only few drugs which are safe in pregnancy, but suppose we have a patient who is pregnant in the 3rd trimester, has a relapse of lupus, is not responding to azaldehyde, azathioprine, hydroxychloroquine, steroids, not responding to pulse steroids. Would you consider rituximab in 3rd trimester, considering the fact the organogenesis is already complete? That's one. If so, what would be the protocol? And how would you weigh it against the other second-line therapies such as IVIG or plasmapheresis against Ritux? If
The patient is already on. And patient is on. She has received only pulse steroids and not any other drug. Okay, let us ask. I would like to comment on that, but then, do we have any views on that? What he is asking is 3rd trimester relapse. She was given steroid pulse and she has not responded. No views? Yeah.
I would like to tell how we dealt with this particular patient. So she came to us somewhere around 26, 28 weeks or so, a little bit late, like she was walking around with a flare. And by the time she came to us, there were 2 issues. One, she was in a renal flare, and second thing is she had a crop of genital warts also. And the genital warts was so bad that it was thought that probably she will have to undergo a C-section at term. So basically there was this question, if we don't intensify the immunosuppression, she's going to lose the kidney. The second thing is actually, of course, we have to take into this consideration this warts also. So what we did was, we gave a methylprednisolone pulse and started her on aspirin and had parallel sessions of cauterizations planned for these patients. So the warts were too much that it cannot be taken out in a single session. So dealing with the warts took almost around 3 or 4 weeks, but by the time her creatinine has started increasing on steroids and azathioprine. So then what we decided was, probably the original plan was to add on CNI, but by 4 weeks it was clear that probably she is not responding with the creatinine increasing and proteinuria increasing. So we did proceed with rituximab. The problem with the rituximab is basically if you give it too close to delivery, there is a possibility that it can produce some bone marrow suppression in the child. So her second dose of rituximab, if I remember correctly, was given somewhere around 32 weeks. And her delivery was planned around 36 weeks. So probably there is a theoretical risk of, I would say theoretical risk. People have given rituximab towards the delivery also. What I would say is, in such a scenario, you have to deal with lupus. You have to deal with the flare. There is no way out. And if the patient is not responding to your conventional therapies, considering cyclophosphamide versus rituximab, probably I still feel that a better solution might be rituximab and not cyclophosphamide.
The point I would make there is, before going from steroids directly to rituximab, I don't think that is a good idea. You are asking about steroid, patient has not responded, and yeah, so in that situation, I'm telling generally, if the patient is on steroids, patient has got azathioprine, if the renal function is normal, we can consider adding CNI also, and then if the patient is then resistant, then that becomes an indication for giving rituximab also. I thought the question was whether the patient is now has not responded to steroids, can we directly give rituximab? I will probably not do that. We will try, like the patient got azathioprine, I would probably give some CNI also if the renal function is normal, and then as a next step go to rituximab.
One of the other issues is how good an neonatology unit you have also. So whether you can plan an early delivery. So I think my unit is quite comfortably with 28 weeks. So of course 28 weeks I would not, I would try to get it down to 32 weeks. Like you said, you had got to 32 weeks, probably I would have planned delivery early in order to allow that further drugs can be given after delivery.
Yeah, so that's a good viewpoint also. Thank you for that. Vijay?
Sir, thank you for this giving the opportunity.
My question is that she has mentioned the mini pulse of a steroid. So what is the mean of that? Like it's 125 or 250 or lesser than that?
I believe anything less than what we usually give is say 15 milligram per kg. So this will be 7.5 or even less than that will be a much smaller dose of methylprednisolone.
But in lupus, like we know that hit hard theory is good for the flare.
Yeah, so that's true. But then if you look at overall the use of steroid, I'm telling say uncomplicated steroids. If you look at the last few decades, the use of steroid dose is actually coming down. If you look at the recommendations also, the dose recommended is also coming down. So what was considered standard, I think, has changed now. A lower dose is considered standard. So this will be an even lower dose.
Thank you.
Patient was using prior spironolactone and they have conceived. So what should we do? Whether we should terminate? It is a category C drug. So you told ACRBs we can stop and continue pregnancy. For spironolactone, is there any recommendation?
I don't know honestly. I have not. We have not faced that situation. But I can't tell you authoritatively.
Spironolactone, I think, is not recommended in any of the trimesters, so should be stopped.
The other, yeah, please.
Say if the patient is not responsive to your steroid pulse followed by CNIs as well as unadded antiproliferatives. So,
Yeah, so
do you consider pheresis more than rituximab?
So I recently had an opportunity to look at the treatment of a resistant lupus nephritis. Based on that literature review, I would say that it's rituximab, which is, if you look at the available data, which is likely to work more, which is likely to be more effective in resistant lupus is rituximab rather than plasma exchange. Plasma exchange is generally recommended in situation where you don't want to further intensify immunosuppression because the risk of your assessment of the patient is that patient is at high risk of infections, so you don't want to give, and then still you want to treat it, then you go for it. But if you look at the effectiveness in resistant lupus, I'm not telling general, resistant lupus nephritis, it is rituximab which is more effective compared to plasma exchange.
One more doubt is, as far as the MTT therapy is concerned, the CNI dose is a targeted dose. We all know that with CNIs, with that level of CNIs, we will not be able to achieve a necessary dose which is needed for immunosuppression or for therapy per se. It's a fixed dose regimen which is being used. So what will be the general consensus of this group when we are advocating MTT for a pregnant woman? So is it better to go ahead with the fixed dose combination with the Chinese protocol has used, or will we should be targeting more the CNI ranges which has been used in the FSGS and the photocytopathy group? The MTT regimen which they have used is a 2 to 3 gram, that's a fixed dose regimen. So we all know that with this level it will be very difficult for us to achieve the targeted dose. So probably the CNI which we are giving may not act in a patient in a way if we want to tell. So what will be the best way to go about in these cases in pregnant women?
Again, any views from the audience? Premada, you want to comment on that?
Now, about tacrolimus, you see, the dosing is only, I mean, the tough levels are all defined only for transplant recipients. It's not been defined for other conditions. But in generally, in glomerular disease, we would like to achieve, our target is not to produce toxicity. So we would try to avoid high doses. But generally, 4 to 5 nanogram is targeted generally. And that's probably a safe level. And probably, I think even in lupus, maybe we can try even 5 to 6 or something like that to see whether effectiveness. But we don't know effective doses in these diseases.
Yeah, I agree with what Dr. Satish said. See, it's a fixed dose protocol in the Chinese study. Of course, actually, the long-term benefits of the Chinese study is plus minus because the follow-up actually you didn't see any sustained benefit. So maybe it might be working by a hemodynamic effect on. And the only target is do not go for supratherapeutic doses. So maybe you start off with the dose which is possible, which you are comfortable, which usually would fall in 40% range. With the therapeutic drug level monitoring, ensure that it doesn't go above the supratherapeutic range. Rather than chasing therapeutic ranges as we do in transplant, we don't even know whether the strategy is going to work.
But your KDIGO 2024 guidelines in lupus nephritis, at least in the general population, that tells you to target around somewhere around 5. And the duration has to be somewhere around 3 years for you to say it's resistant per se. And what KDIGO actually says is CNA per se is preferred whenever there is more of a podocyte involvement. But whether we do an electron microscopy is like, that's totally different question.
The only point I wanted to make was it is not necessarily through immunosuppressive mechanism alone there is a reduction in proteinuria or remission. So it's not necessary that we should have a, you may get away with reduction in proteinuria. It may result in other manifestations at a lower dose also. Jitu had a I won't say I know the exact answer to that, but my belief will be if the I will not go only by the titers. Okay, even if the titer is has gone up a little. Usually also it says that there is a fold rise and all, right? So if it is just the titers, I would probably still allow the patient to go ahead and conceive. Just because the titers had increased, I probably will not stop. I think we have taken too much time for this session. We have exceeded even though the so can we, if we don't have any more questions, can we wrap up the session?
We request Dr. Karthikeyan to kindly present mementos as a token of regard to our chairpersons. Sir. There is an announcement to make. The delegates who have registered for poster presentation are requested to paste their posters against the numbers allotted to them. The name list with the numbers is put up opposite the registration desks. We shall all now break for tea. Refreshments will be served in the adjoining hall. Please rejoin us in 15 minutes for our next session. Thank you.
We request the delegates with presentation.
Correction.
Good evening to everyone. We will be beginning the session shortly. We request everyone to gather. We request the delegates with paper presentation today to kindly submit their PowerPoint.
Welcome back, everyone. Our next session focuses on recent advances in understanding the pathogenesis and biomarkers of preeclampsia. This discussion shall explore emerging biomarkers, including angiogenic factors and placental proteins that enhance early detection and risk assessment of preeclampsia. This session will be chaired by Dr. Sandhya Suresh, Assistant Professor of Nephrology at SRMC Chennai, and Dr. Sabrina, Assistant Professor of Nephrology at Jipmer Pondicherry. We invite the chairpersons onto the dais.
We now invite our esteemed speaker, Gomati, who has the distinction of establishing the Department of Nephrology at Government Medical College, Alapura, where she currently heads the department. Ma'am is an acclaimed clinician and teacher and is a recipient of the Best Doctor Award bestowed by the Government of Kerala. Please, ma'am.
Respected senior members of the faculty, distinguished delegates, and dear friends, at the outset I thank Dr. Srijit and his team for this, giving me this opportunity for this, to participate in this wonderful update session on pregnancy and kidney disease. As you all know, preeclampsia is a hypertensive disorder of pregnancy with onset after 20 weeks of gestation. With proteinuria or maternal organ dysfunction, it complicates around 2 to 8% of pregnancies. And it has been classified into preterm, term, and postpartum preeclampsia depending upon the time of onset of the preeclampsia. It can also be classified based upon the early onset or late onset depending upon the onset before or after 34 weeks of gestation. The time of preeclampsia onset, that is thought to reflect an underlying difference in etiology between these different types of preeclampsia. Placenta is central to preeclampsia. This placental disease, preeclampsia, progresses in 2 stages. In stage 1, it is initiated by an abnormal placentation, which occurs in the early first trimester, and this progresses to the second stage, that is a maternal syndrome, which happens in second or third trimester of pregnancy. So before going into the details of the abnormal placentation, let us just quickly revise the steps of normal healthy placentation. Pregnancy is initiated following implantation of a competent blastocyst into a receptive endometrium. Following implantation, the placenta is formed from extraembryonic lineages. The trough ectoderm cells differentiate into cytotrophoblast. The cytotrophoblast will fuse to form the synesthesia trophoblast, and this trough ectoderm cells, the cytotrophoblast, also differentiate into a very important cell called extravillous trophoblast. This is very important for vascular remodeling, and the defect of which is responsible for the preeclampsia. And again, the extraembryonic mesoderm will contribute to a core of stromal tissue with blood vessels inside the chorionic villi. The cytotrophoblast form a cell column, and that harbors the villi, chorionic villi, into the decidua. And if you look at the decidua, you will see that lots of cells infiltrating that area. The predominant cells are the uterine natural killer cells and T regulatory cells. These cells, along with the extravillous trophoblast, will take away the muscular layer, the tunica media of the spiral arteries. And finally, the spiral arteries will be converted into a low resistance, high flow system. and its terminal portion is just like a funnel, and it gives blood to the growing fetus. It can, because of this remodeling, that can meet the demand of the growing fetus. And the pathogenesis of preeclampsia, the term and preterm, is slightly different. In the preterm preeclampsia, this pathogenesis is initiated by a poor spiral artery remodeling, the process which we had just mentioned, that can lead on to reduced placental perfusion and placental hypoxia. And in term preeclampsia, two mechanisms operate. One is a placental compression, that is, a chorionic villi is compressed by the expanding placenta, and next is the syncytiotrophoblasts senescence caused by the premature placental aging. So all these will contribute to a placental hypoxia and ultimately will result in syncytiotrophoblastic stress. That is a corner event in the genesis of preeclampsia. That stress will lead on to release of lot of mediators into the maternal circulation, the anti-angiogenic factors, the reactive oxidant species, syncytial node, pro-inflammatory cytokines, so on and so forth. And that is responsible for the maternal syndrome. So, in short, a defective remodeling of the spiral artery occurs to begin with, and that will lead on to defective placental perfusion, leading on to release of various factors into the maternal circulation, resulting in the maternal syndrome of preeclampsia. Now the question is, what triggers the defective remodeling of spiral artery? So let's go through the cues and signaling pathways regulating this abnormal placentation. So many theories have been put forward: the genetic theory, the theory of inflammatory response, immune imbalance in the maternal fetal interface, theory of oxidative stress, theory of vascular endothelial cell damage. All these theories have been put forward for as to the cause of abnormal placentation. So now we'll revise what is the genetic theory. Most cases of preeclampsia are sporadic, but in 1/3 of cases, the genetic factors are thought to play a role. And the incidence is increased in individuals who have immediate family member having preeclampsia. The incidence increases by 2 to 5 times. In another study from Norway showed that women born out of preeclamptic pregnancy has a 2.2-fold increased risk of preeclampsia during her pregnancy. So a genetic predisposition to preeclampsia is supported by these observations. In men, for men whose mothers had preeclampsia, they increase the risk of preeclampsia in their spouse. So preeclampsia is thought to be the result of a complex interaction between maternal and fetal genotypes in addition to the environment. Now we will move on to the next mechanism, that's the theory of inflammatory response. We have already seen that the decidua is infiltrated with lots of immune cells, the T regulatory cells, macrophages, uterine natural killer cells, and probably the dendritic cells. These 4 cells are very important in the normal implantation and the normal decidualization. These are very important. These cells, especially the uterine natural killer cell, in association with the extravillous trophoblast, is responsible for the spiral artery remodeling. Moreover, this will encourage the EVT to penetrate deep into the myometrium. That will result in a better placental remodeling, resulting in prevention of preeclampsia. So any local imbalance of these factors or these cells can result in preeclampsia. So the uterine natural killer, it's very interesting to learn how uterine natural killer cell participate in genesis of preeclampsia. They regulate, as I said earlier, the depth of trophoblastic cell infiltration is predominantly regulated by the uterine natural killer cells. And if you look at it carefully, the uterine natural killer cell has on its surface a receptor expressed that is called killer cell-like immunoglobulin receptor, KIR. In the normal pregnancy, the KIR receptors on the uterine natural killer cell will identify the HLA-G molecule expressed on the trophoblastic cell. That's a fetal origin. So that will result in a normal placentation. But if the KIR is of inhibitory variety, this will recognize the trophoblastic HLA-G molecule. So if the HLA-G molecule come in contact with the inhibitory KIR of uterine NK cell, that can result in defective placentation. The T cells in normal pregnancy, T cells, the naive T cells, Th0 cells, will differentiate into one of the 4 different cells when they are exposed to the antigen presented by the dendritic cell. So, which cell is to be differentiated into? That is decided by the cytokine milieu prevailing at that point of time. But in normal pregnancy, it is predominantly the Th2 cells and T regulatory cells which are formed from naive CD4 cells. But in women who are destined to develop the preeclampsia, Th1 and T17 cells are mainly formed from CD4 cells. So, in the normal pregnancy, the cytokine profile and the cells are predominantly anti-inflammatory, whereas in preeclampsia, it is mainly the pro-inflammatory cytokines and the cells which respond to inflammation are predominating. So, in effect, a pro-inflammatory milieu is prevailing in preeclamptic patients. Another important cell is a macrophage. As you all know, the macrophages have 2 different phenotypes, M1 and M2 phenotype, of which the M1 is pro-inflammatory and M2 is anti-inflammatory. In pregnancy, M2 macrophages, M2 phenotype dominate, and that helps in normal placentation as well as in prevention of rejection of the fetus. The next interesting cell participating in this normal preeclampsia, genesis of preeclampsia is a dendritic cell. So the naive CD4 cell, whether to differentiate into T regulatory cell resulting in tolerance, or the naive CD4 cell to differentiate into the Th1 cell, that depends upon the nature of the dendritic cells by which the antigen is presented. If it is an immature dendritic cell with low levels of immunostimulatory molecules expressed on its surface, the tolerance result. But if a mature dendritic cell which express high levels of immunostimulatory molecule, that will result in a pro-inflammatory phenotype, that is Th1 cells, resulting in preeclampsia. So it is very interesting to note how the fetus is being tolerated by the mother. Fetus is considered as semi-allograft because half of his genes come from the father, making it genetically different from the mother. So naturally, the mother's immune system could potentially reject the fetus. However, the mother's immune system is able to tolerate the fetus for an extended period of time during pregnancy. How is this brought about? It's again the balance between pro-inflammatory and anti-inflammatory cells which infiltrate the feto-maternal interface. That plays a major role. So, if you look at the NK cell, they are the major cells. The NK cells can identify the histocompatibility complex ligands on the trophoblastic cell. The equation is very simple. If the NK cells of the uterine NK cells, if they come across HLA-G of the trophoblast, that will result in tolerance. If they come across HLA-C of the trophoblast, that will result in preeclampsia, FGR, and sometimes even fetal demise. And other cells which are of anti-inflammatory nature, like decidual macrophages with M2 phenotype, T regulatory cells, Th2 cells, all this will favor the tolerance of mother towards fetus. That is again important for the normal placentation. The complement system is in fact a bit downregulated during normal pregnancy. That is probably because the placenta releases lot of complement regulatory proteins. So the complement system is actually a weapon in the hand of immune system to kill the targeted cells. So that is a bit downregulated during pregnancy. That will also help in fetal tolerance. So when the feto-maternal tolerance is lost, abnormal placentation, abnormal placental immune function results, ultimately resulting in intense inflammation and then preeclampsia. So now going to the theory of oxidative stress. Lots of reactive oxidant species and toxic lipid peroxides accumulate in pregnant individuals who are destined to develop preeclampsia. This may be a cause or a consequence of preeclampsia, but this can activate various cell types like monocytes and neutrophils, can release lot of pro-inflammatory cytokines. Also, it can cause mitochondrial oxidant stress by damaging the mitochondrial membrane. Ultimately, this can lead on to preeclampsia and even sometimes premature rupture of membranes. And theory of vascular endothelial cell damage. The endothelial health is very vital for the normal placentation, as you all know, and it is mainly maintained by two molecules, that is vascular endothelial growth factor and nitric oxide. And in preeclampsia, SFLT, that is the anti-angiogenic factor, increases, and the pro-angiogenic factor decreases. The normal endothelial cell health is very important to reduce inflammation, thrombosis, and to improve the microcirculation. And this nitric oxide acts as a significant link between the oxidative stress and vascular endothelial damage. Next is the oocyte donation in vitro fertilization. We had heard about the in vitro fertilization in the earlier deliberations, and in vitro fertilization probably causes the preeclampsia, possibly because it is associated with the absence of corpus luteum and consequent relaxin deficiency, which can in fact disturb the maternal circulation and predispose the mother to develop preeclampsia. The oocyte donation may be considered as an independent risk factor for preeclampsia, because this probably is related to immunological intolerance or immunological maladaptation. Then among women with pre-gestational diabetes, preeclampsia complicates around 10 to 20% of the pregnancies, and gestational diabetes and preeclampsia share many factors in common, like advanced maternal age, nulliparity till gestation, etc. So another important molecule I would like to highlight upon at this juncture is the AT1AA, that is agonistic autoantibodies which bind to angiotensin 2 type 1 receptor. The importance is that in normal pregnancy, the renin-angiotensin-aldosterone system is activated, whereas in preeclampsia, the RAS system is a little bit down-regulated. So the hypertension of preeclampsia is not mediated by angiotensin 2. It is mainly mediated by it is postulated that this agonistic autoantibodies, this can bind with the AT1 receptor and can mediate hypertension. More than that, these antibodies also can upregulate the anti-angiogenic factors. So very important point to remember in our day-to-day practice is that it has been said that women with preeclampsia, history of preeclampsia, they have got adverse cardiovascular health in the long term. And that is probably due to persistent maternal endothelial dysfunction caused by the persistence of these AT1 antibodies. And majority of the mediators released into the circulation during pregnancy will be cleared off post-pregnancy. But this molecule is known to persist in the maternal circulation and can cause diffuse endothelial dysfunction and its long-term consequence. So in short, genetic factors, inflammatory response, immune imbalance, oxidative stress, vascular endothelial cell damage, all will cause a release of a gamut of pro-inflammatory factors and cells with pro-inflammatory response into the maternal circulation, resulting in maternal endothelial multiple organ dysfunction and fetal involvement. The postpartum preeclampsia is which develops 6 to 8 weeks after delivery. The pathogenesis probably can be explained by the delayed clearance of anti-angiogenic factors in these patients, or probably due to activation of complement system after delivery, or it may be due to a response to mobilization of the extracellular fluid into the intravascular compartment. So, in short, the molecular pathways in the symptoms of preeclampsia usually appears after 20 weeks, but the pathogenic pathways appear quite very early in the pregnancy. Moreover, the criterion standard has got significant drawbacks. It has got a very low positive predictive value. So, an effective predictive test in the form of biomarker would facilitate an early diagnosis, a targeted surveillance and timely delivery, and for a safe landing for both mother and the fetus. So now we will move on to the second part of my discussion, that is biomarkers in preeclampsia. For predicting preeclampsia. Why do you need a biomarker for predicting preeclampsia? If you can identify a woman sufficiently early who is at risk of preeclampsia, you may institute a preterm. The term preeclampsia, it is not very much valid. So, in fact, the early onset, the preeclampsia that is occurring before 34 weeks complicates just 0.38% of the pregnancies, whereas the term preeclampsia occurs at more than 7 times that rate. And term preeclampsia can be very severe and can contribute significantly to global maternal and perinatal morbidity and mortality. So, as of now, because the screening does not predict most cases of preeclampsia, clinical triage remains a time-honored approach. As you know, at each antenatal visit, we have to measure the blood pressure, we have to screen for proteinuria, we have to do the lab tests for detecting HELP and other complicated issues associated with preeclampsia. And as the pregnancy advances, the visits should be enhanced. That is, between 28 and 36 weeks of gestation, we have to advise a fortnightly antenatal visit, and after 36 weeks, probably you can do a weekly antenatal visit. And actually this takes the time, precious time of the pregnant lady, and also increase the cost incurred for the medical management. So besides this first trimester combined screening algorithm, a biomarker innovation for preeclampsia has entered the clinic, and it is mainly applied in the third trimester, and that too in an individual who is at risk of developing preeclampsia or who has clinical picture which is ambiguous. And that is the SFLT1 placental growth factor ratio. It has been found to have greater diagnostic significance in the prediction of preeclampsia. So this placental growth factor, as you know, is a pro-angiogenic factor. It increases in the first trimester of pregnancy, reaches a maximum by about 30 weeks of gestation, and its levels are correlated with the partial pressure of oxygen. In preeclampsia, there is an intense placental hypoxia. So the placental, PLGF levels are almost not detected in severe preeclampsia, whereas the anti-angiogenic factor SFLT levels increases very much in patients with severe preeclampsia. Mind you, it is elevated even before the patient develops hypertension or proteinuria. So rather than using this markers, either markers alone, a combination has been found to be more useful, and prognosis is a multi-center observational study. This is designed to investigate the value of this, and is found to be very useful. A value of less than 38 has got a strong negative predictive value in at-risk individual. In fact, this the ratio, SFLT placental growth factor ratio, can be compared with that of a traffic signal light. A ratio less than 38, that's a green light group, they are unlikely to develop a preeclampsia and its complication within the next 4 weeks. The yellow light, that is the ratio between 38 and 84, they are likely to develop preeclampsia in the next 4 weeks. In an at-risk individual, they require close follow-up. In the red light group, they are likely to develop this complication in the next 1 week. So they require immediate hospitalization, they require immediate evaluation, lab test, all this cardiotocographic evaluation, and based upon this, we take a next decision. So it is an additional and advanced diagnostic tool for preeclampsia, independent of blood pressure or laboratory marker related to HELP syndrome.
3 more minutes to go.
I may require 7 minutes. Is it possible? Okay, thank you. So the ratio, is it different from the singleton pregnancies, different in twin pregnancies? That is the next question. So it has been, the data has been analyzed in 3 major studies and found that the twin pregnancy up till 29 weeks, the ratio holds, it is not different, but after 29 weeks, probably the ratio becomes higher for twin pregnancy compared to singleton pregnancy. So all these tests and all these ratios, all these are predictive of a preterm preeclampsia. In fact, a rule-in test for term preeclampsia is still not available. So if such a test were available, we could have reconfigured the antenatal clinical care. We could have reduced the number of antenatal visits, number of tests, the cost and time of the pregnant lady we could have saved. So that remains an unmet need. So apart from this SFLT, placental growth factor and the ratio, many other molecules have been described, but these molecules have only a modest predictive performance, and they are yet to be validated before it being introduced widely in our clinical practice. And these biomarkers should be applied to a high-risk individual, and that too in the late trimester, around 28 weeks. And currently, there are no clear recommendations for the practical use of angiogenic biomarkers in the detection and treatment of preeclampsia in routine clinical practice. So probably it is due to an increased cost, decreased availability, accessibility, lack of validation for all this. It is not widely available. So that is actually a concern for the treating doctor. So novel biomarkers for preeclampsia. So it is mainly focusing on the potential biomarkers which are released from the organs involved in the pathogenesis of preeclampsia. As you know, the placenta is the main culprit. So placental disease, placenta releases a host of nucleic acids into maternal circulation during preeclampsia, and that is detectable during pregnancy, and post-pregnancy, post-delivery, that disappears very fast. So that can be considered as an important biomarker. They are mainly the messenger RNAs, microRNAs, the circular RNAs, various metabolites and proteins, and the novel biomarkers for preeclampsia are the RNAs and proteins related to placenta and the endothelium. So these biomarkers, various biomarkers have been described. The placental and cardiovascular biomarkers in combination can have untapped potential for prediction of or risk stratification of preeclampsia, but must be rigorously validated in external cohorts before being introduced into the clinical practice. So as of now, the CNAPs, circulating nucleic acids in maternal plasma and serum, the use of these CNAPs in clinical practice is not recommended, because it is difficult to draw firm conclusions around the value of this. We don't have a good method to detect the microRNAs so far. So what is a pragmatic time for screening for preeclampsia? Like predicting the weather, screening tests for preeclampsia, they generally perform better closer to the disease development. So it is often done, it is often sampled at around 28 weeks of gestation, and that too in at-risk individuals. And tests may be repeated at a later point of time in gestation. Sometimes it may help. So to summarize, the angiogenic biomarkers, they are a major leap ahead in helping to better identify women at risk of preeclampsia-related complications. The ratio less than 38 has got a very strong negative predictive value for preeclampsia in the next 4 weeks. So this warrants its inclusion into the predictive and diagnostic clinical workup. This has already been achieved in Germany and many parts of Europe. We too should adopt. So what we should do is the risk stratification using the guidelines. You can do it in the first trimester. As the gestational age progresses, you can refine the risk stratification further by adding other tests like Doppler, pulsatility index and all can be identified. Biophysical tests can be identified. At around 28 weeks, you may use biomarkers in an optimum combination to identify women at highest risk of developing preeclampsia. So cost is definitely a factor, validation is another factor, but when I checked with the website of Government of India, under National Health Mission, the government has formulated several schemes for facilitating the checkup and screening of pregnant women. So as treating doctor, I think we should utilize one or more of these schemes, and we must be able to bring the biomarkers with high predictive performance to our doorstep at reduced cost for the deserving. So I have tried to give a brief overview of the topic given to me, and this is another question to the postgraduate students in the floor. So this is a famous personality, is an Indian nephrologist who has done a lot of work in the field of biomarkers, pathogenesis of preeclampsia and biomarkers. In fact, he had done the investigations regarding the angiogenic and pro-angiogenic factors. Anybody? Any postgraduate student? Postgraduates?
Yes, who told that?
Sir.
I think he's Dr. Anand Karmanji. He's an Indian person.
Yes, sure. Good. So it's Dr. Anand Karmanji, and he has actually received his medical degree in 1992 from the University of Madras, India, and we are really proud of our colleague. And ladies and gentlemen, let me wind up my discussion by reminding you that there is an area with ample scope for research in our country, which can ultimately improve the quality of life of our beloved mothers and babies, both in short and long term. Thank you. Thank you once again for the patient listening.
Thanks, ma'am, for the excellent presentation and explaining the pathogenesis in depth about preeclampsia. So the pathogenesis of preeclampsia is not as simple as we think. It involves genetics, it involves dysregulation in the immune system, as madam has told, and it involves more of oxidative stress, and also there is some sort of autoimmunity that has been elucidated well. So this marker, SFLT2 and placental growth factor ratio,
It has a very high negative predictive value, almost like 99%, but the positive predictive value is only 65%. As FDA has approved it after the precise study which has come 2 years before. I think this marker was approved by FDA for risk stratification of patients who may develop preeclampsia in March 2023. So I think the cost is the issue for this marker, and probably if it is negative, probably the negative predictive value is high. So thanks ma'am, thanks for the excellent presentation. Any questions from Dr. Sandhya and from the floor?
Would this biomarker also be useful in patients with CKD who get pregnant, ma'am? And would the cutoffs change in this population?
I'm not very sure on that. So I have not reviewed literature on CKD.
They have not been, because
the pathogenesis is the imbalance between the progenic and angiogenic factors. My point is, when we talked about pregnancy and preeclampsia, so initially to begin with, we thought it was to include proteinuria as a part of the preeclampsia was considered important. But over the period of time, it's been one of the, along with the other. So don't you feel the pathogenesis in preeclampsia which affects the kidney, we were talking about endothelial dysfunction and the changes, but there is some data to suggest that there are changes happening very much in the podocytes. So could podocyturia or podocyte markers help us predict that these ladies, because these ladies have a cardiovascular risk subsequently over a period of time, and there are data to suggest that 4 times the risk to patients to get CKD. So could that, because we've tried in doing in our population, we weren't able to, we did find a rise of podocytes and the markers during the pregnancy and later did 6 weeks. Beyond 6 weeks, we were not able to predict that. So could that be an important marker to build?
Some of these angiogenic markers can cause podocyte damage, podocyturia, and that is one of the mechanisms responsible for proteinuria and preeclampsia. So podocyte related markers can definitely be, should also be considered. That's why I said there's a scope of research, lots of scope for the research in this area. It is not the endothelial dysfunction as alone responsible for proteinuria. Podocyte is also contributing.
Any questions from the floor?
I have a question.
Yes, sir.
Yeah. So, I mean, rather than a question, a comment. You're saying about the SFLT PLGF ratio to be used for triaging a patient with suspicion of a preeclampsia. Mind you, if you look at the literature and the guideline which was published in 2021 by the ISHP, they have put a query on those studies. The fact was, most of them said that the population they studied was suspected preeclampsia, right?
Yes.
And
yes,
all
sir.
those
Yeah.
patients with suspected preeclampsia in our setting are labeled as preeclampsia. So then, where will we do that test? When we have all the patients wherein which was included in the population as a suspected preeclampsia has been considered as a preeclampsia, has been treated as a preeclampsia, the role of this testing in our setting itself is a questionable one. The second one is, when you said the ratios of 38, 85 and all those things, okay, this was utilized to triage the patient in a high income setting in Liverpool Women's
Yes.
Hospital, right?
Yes.
What changed was, the only thing which this changed was the number of patients which increased the admission. The number of patients who undergo the sections went to roof, and they finally called off saying that they withdrew the stratification by using of an SFLD PLGF ratio. Yes, it's a good marker, but it is still to come up in a validated way. But the marker which is more found to be useful is the PLGF. PLGF definitely has a role, and along with mean arterial pressure, the uterine artery, this thing, and even the FIGO, the WHO, and all the setting, the 4, if you don't have a PAPE, you can even replace it with the PLGF, or you can have a combination of a mean arterial pressure, the uterine artery Dopplers, and the PLGF, which will actually increase the sensitivity to something near about 70, but it's not good enough.
Yeah.
They're saying it's not good enough. There are other markers which comes in is like, now they are phenotypically different, these groups are. So even the cardiac markers are coming up with echoes. They are coming up with the arterial this thing. So there is scope of lot of research. Unfortunately, our ICMR doesn't put, if you see the National Health Research Priority Project which was published in 2021, the maternal health is completely out. The whole thing what is included are 3 under the RCN divisions. One is anemia, malnutrition, and neonatal mortality. So there is nothing about mother, which was initially used to be there in the ICMR, is all been removed, and they said the maternal health is not a priority anymore. We have spent so much of funds for reducing the maternal health. I'm sorry. It's
Yes,
just
thanks,
a
sir.
comment.
Thanks for the excellent comment. Yeah.
Thank you, ma'am, for the wonderful session. We request the chairperson to felicitate ma'am. We request Dr. Shwati to felicitate the chairpersons.
Thank you, ma'am. We shall now move on to the next session. The sixth session is on chronic hypertension with superimposed preeclampsia. This session will be chaired by Dr. Maitri Shankar, Assistant Professor, Institute of Nephrourology, Bangalore, Dr. Avinash Kumar Dubey, Consultant Nephrologist, Guru Nanak Hospitals and Research Center, Jharkhand, and Dhanan Pudiotal, Assistant Professor, Nephrology at Government Medical College, Kannur. We request the chairpersons to kindly come onto the stage and occupy their seats.
We now invite our esteemed speaker, Dr. Anish Keepanasheral, Professor Obstetrics and Gynecology, Jipmer. Sir is an alumnus of the prestigious PGIMER Chandigarh and has a keen interest in the field of obstetric medicine, in which he went on to pursue a postdoctoral fellowship as well. Sir, please.
Thank you for the introduction. Let me just correct, I am not in a postdoctoral fellowship in obstetric medicine. Rather, I am a coordinator of the postdoctoral fellowship which is happening in Jipmer. So, I am an obstetrician in front of all the nephrologists. I can say, I'm sandwiched between all the nephrologists with esteemed madam talking about the various pathways of the preeclampsia. I mean, it was an extensively covered session to set up the tone for what you're going to talk about in the next session. So can I have my slides? So my topic is on chronic hypertension with preeclampsia, but I'm going to deviate a little bit from that to include a bit more about the preeclampsia per se. Because one of the reasons is, as you know, that the pregnancy, I can talk about my couple of slides before it comes up. So if you know the physiological changes of pregnancy, one of the tough thing is to differentiate someone who has a chronic hypertension from having a, is it just started with pregnancy or was it there before the pregnancy? So these were the learning objectives which was given to me by the team. So I'm going to cover in the various heads. So this was a case scenario of a 27-year-old primary gravida who was found to have BP in her first antenatal visit at 12 weeks gestation. There was no prior history of kidney disease. No slides are not moving, I'm sorry. Oh, yeah, I have to do anything. No. So she's a 27-year-old who had no prior kidney disease with a history, no history of any UTI or so. And she was started on a single antihypertensive. She was referred to Jipmer with a BP of 160/100 at 25 weeks of gestation. And her lab investigation showed a mildly increased creatinine of 1.16, a low serum albumin of 2.2, a urine PCR of 17, and urine albumin was 3+, and KUB showed no abnormalities. So before we go into the topic, let me just take you through a few physiological changes which happens in pregnancy. The cardiac output increases by 30 to 50%, and there is various changes in the plasma volume and the coagulation system, which actually helps to continue the pregnancy and to cope up with the blood loss which happens in the postpartum. So various other factors which increases the risk to the mother include the presence of having a multiple pregnancy, and now almost the whole population, there is a shift towards more of patients to have an overweight and obesity. That increases the risk further presence of anemia, which is a chronic problem which is there in our community, and the presence of diabetes because of the high incidence of obesity and the various metabolic reasons we have. All these actually increases the risk of a patient who becomes pregnant. So if you look at the physiological change, you can see that there is a dip of the blood pressure which happens at something around the mid-trimester, right? And then subsequently it is going to go up, and then it is going to pick up to where it was in the pre-pregnancy time period by maybe around 30 to 32 weeks. So it's very challenging if a patient comes to you for the first time at 20 weeks to say that 24, 22 weeks to say that is this patient having an underlying chronic hypertension, or is it having preeclampsia? So what do you consider as a high blood pressure in pregnancy? So recently the definitions has been changed, and the AHA has told that anybody who has got a BP of 130/90 or more is to be diagnosed to have a hypertension. But the various revisions of hypertension in pregnancy and the diagnosis, even the 2021, the 2023, the SOMANS guidelines, and all of them stick to what it means to be the original definition of a stage 2, which is in a non-pregnant stage. That's anything more than 140/90 if it is found during any time during the pregnancy is a hypertensive disease. Now the terminology and the classification varies based upon when it is supposed to come for the first time. So if a patient present to you with a BP, if it is present before 20 weeks, either during the pre-pregnancy time period or at less than 20 weeks, you find, just like in our case, the patient is actually diagnosed to have a chronic hypertension. If it is between or after 20 weeks and it goes on till the 12 weeks postpartum, you can call it as a pregnancy-induced hypertension, which again is classified into different as gestational hypertension in the absence of proteinuria or a target organ damage, or preeclampsia, especially if you have a presence of having a target organ damage or a proteinuria. Then there are two complications which again form part of the preeclampsia, which are the eclampsia and the HELP syndrome. So hypertension which is known at less than 20 weeks, we can think about it in three different heads. One, it could be a chronic hypertension. Either the patient has an essential hypertension, which is otherwise in a non-pregnant patient, or it could be a secondary hypertension, which is maybe because of an underlying problem which is already there. There are two more categories which has been described by the International Society for Study of Hypertensive Disorders of Pregnancy. One is the white coat hypertension. That means that the patient is found to have a high BP when she visits you at clinic. And when she goes back home and have the home BP recordings, it's not going to be found in the subsequent recording. Or it could be a masked hypertension that you have a normal recording, whereas the out of office or the home BP is supposed to have a high BP. So let me just take you to the various etiology of the chronic hypertension. So it could be a primary or an essential, which is found to be in the majority of the patients in nearly about 9 out of 10 patients. And maybe 5 to 10% of all of the chronic hypertension might be secondary, affecting the various systems. So you can have a systemic approach to look at that, what are the causes. It could be a renal cause, which is much more common in a woman. In the reproductive age group, autoimmune disorders, which are much more common in the reproductive age group. It could be possibility of a vascular disorder, which could be like a pulseless disease like a Takayasu arthritis, or even it might be a cardiovascular problem like a coarctation, which might be presenting later in the adult life. There are endocrine disorders which could be associated with secondary hypertension. And the common one being now, most of the patients which we come across in our renal clinic may have a hypothyroidism or hyperthyroidism, which might be contributing to the development of having a chronic hypertension. So let me just brief you through one of the common ones which has been described, and there is a Delphi consensus which has been published recently on how do we diagnose someone to have a white coat hypertension. So conventionally, the ambulatory hypertension is not very much used in pregnancy, and this is one conditions where ambulatory hypertension has got its own role, that if you find someone to have a high BP in your clinic, and subsequently from the home records you don't find the patient to have any high BP, there are two ways to go ahead. You can either tell the patient to have 2 to 3 times a day and check in a paired reading and come back if you have a high BP, no. And then also you can do admit the patient, or if you have an office-based ambulatory BP, you can send the patient with an ambulatory BP monitoring and see that the patient has got a normal BP. So if you have the clinic recording to be having a high BP, but your subsequent BP having no further home BP recording, or the ambulatory BP is supposed to be less than 130/85. Now, when we say 130/85 in an ambulatory BP, it is equivalent to 140/90 what you see in the clinic or the home BP. So home BP or the ambulatory BP of 130/85 is equivalent to what we see in the clinic as 140/90. So any recording of more than 130/85, it's not a white coat hypertension, it is a persistent hypertension. And if it is less than that at home, and if you are only in clinic, you diagnose someone to have a white coat hypertension. Now what's its importance in pregnancy? It increases the risk of preeclampsia in patients, a relative increase of 5.43, relative risk of 5.43, and an increased risk of small for gestational age and the need of a preterm birth. So, coming to preeclampsia, like Madam said in the previous talk, it's a multisystemic disorder characterized by uteroplacental and maternal endothelial dysfunction. Okay, so you mostly have a high BP. So high BP is even now continued as to be the one of the mandatory criteria for someone to be diagnosed to have a preeclampsia. So proteinuria was supposed to be one of the most important feature, but it has been now thought of as that presence of blood pressure with other end organ damage, which could include a thrombocytopenia, which could have a renal insufficiency, it could have an impaired liver function, or the presence of a pulmonary edema or cerebrovascular symptoms. So presence of any one of the below whatever there is the blood pressure is calling somebody to have a preeclampsia. Now, what do you call someone to have a superimposed preeclampsia? Conventionally, there were two ways of looking at it. So, if the patient was having a proteinuria less than 20 weeks, we used to say increasing in proteinuria to be one of the criteria to be a superimposed preeclampsia. And the other one used to be if you had a normal BP on a patient who had pre-pregnancy hypertension and that patient's BP rises after 20 weeks, then you call it to have a superimposed preeclampsia. But the latest guideline in 2021 changed that scenario that if a patient has the high BP subsequently does call it to be a severe hypertension or the requirement of the drug which is increased. It does not qualify to be calling it as a superimposed preeclampsia. So superimposed preeclampsia is basically by the one of the organ damages which otherwise is called to be known as the preeclamptic symptoms. So etiology is multifactorial. So I'm not going to enumerate the whole. And pathophysiology, as you can know, this placenta still plays. It's supposed to be one of the discoveries in the late 1990s, which plays an important role as the pathophysiological phenomenon, by which the maternal-fetal interface is supposed to be the culprit in the development of a preeclampsia. So adding to that, later people recognize that the phenotypes are supposed to be not same. There is a group of people who just develop late onset preeclampsia. They don't have any problem till 34 or 37 weeks. They develop hypertension or preeclampsia in the later, just in the third trimester. There's a group which develops sometimes in 24 or 26 weeks. And there is one group which predominantly has got fetal growth restriction. Now, one of the things which has come up in the last couple of decades is that there is a difference between what you see in the cardiovascular echocardiography, or if you do an echocardiogram, the cardiovascular hemodynamics shows a different picture in three different phenotypes. You have an FGR which shows a lower systemic vascular resistance, and the cardiac output may be a little lower or maybe normal. And early onset, the systemic vascular resistance is not as decreased as what it has been when patients who has got an FGR. And the late onset, where the cardiac output is increased and the SVR may be just raised or maybe normal. So the different phenotypes actually is paving a way for future research to find that we can individualize the therapy for a patient with preeclampsia. So like ma'am said, now the theory, so it was Redman in 1991 who proposed the two-stage hypothesis. First you have a hit and later you have a manifestation. So the hit happens at least something around 16 to 18 weeks, and the manifestations used to come after maybe 26 or 28 or based upon what the constitutional symptoms or the constitutional factors used to be. So if you see these two, the green and the yellow, so they, according to the latest theory, all the patients who are pregnant are at risk of development of preeclampsia. Had the pregnancy continued beyond term, they might have had developed the manifestation of preeclampsia. Now, this has been documented by two reasons. One, by looking at the cardiovascular hemodynamics, change of the left ventricular hypertrophy and the other changes, and basically on the placental pathologies where they have tried to look at. So, because they delivers by 37 or 38 weeks, they get censored for the development of the preeclampsia. Now, what are the manifestations when someone have a superimposed or preeclampsia? Right? So it could be any of these. It could be thrombocytopenia, which could be, or it could even have a periphosmia, which shows fragmented cells and all evidence of having a coagulopathy or a DIC. And it could be a Press syndrome, it could be a stroke, it could be eclampsia, or it could even be an MI. And some of these patients go on to develop. So the PPCM or the peripartum cardiomyopathy and the preeclampsia may share an underlying common physiology. So they said it might have maybe they are just like brothers or sisters from a two different angle, or it may be developing into a podocyturia or the AK, which someone was raising as the last one, whether we could use podocyturia as one of the features to diagnose preeclampsia, and it may have a plastinal abruption and a fetal growth restriction. So if we the combination or the patients who develop plastinal abruption, fetal growth restriction and preeclampsia currently are together called as what is known as the plastinal syndromes, because they have almost similar pathology to start with. So how do we evaluate and what surveillance we do when a patient has a hypertension? So this is pertaining mainly to a patient who has a hypertension which is diagnosed at less than 20 weeks. So you can look for the various clinical signs and symptoms, the common being the edema, which is much more in the morning, which could suggest a renal disease. Someone who has got a very transient high BPs in the shoots which might be going above maybe 200 by 110 or so and may have palpitations there, then we should suspect to have a pheochromocytoma. A 4-limb BP examination and a pulse might help you to pick up a symbol as two differential diagnosis of a Takayasu arteritis and maybe a coarctation, and you can look for whether the patient is already on some medication which might increase the risk of having hypertension. So you can rule out some of the things by basically doing a simple investigations, doing a renal function test and a urine analysis and an electrolytes. So electrolytes could be the screen for what some of the endocrine disorders. The urine analysis will tell you whether it has got an underlying renal disease, and the renal function test again get deranged if they have an underlying chronic kidney disease. Thyroid stimulating hormones which suggest about hypothyroidism, and you can also think about metabolic syndrome, which could be one of the reasons of having this thing. So echo could be one, it could be help you to find what is the cause of the disease and also to see for the effect of what the hypertension or how long the hypertension has been effect on those. So because women are at risk of autoimmune disorders, especially those who develop a preeclampsia or who has a chronic hypertension who presents with massive proteinuria so at less than 32 weeks, maybe it is useful to do an anti-nuclear antibody test and an antiphospholipid syndrome to rule out the presence of a primary or a secondary APLA, which will give you a much clearer clue. So it has been discussed in length that the patients who might benefit by a change in therapy when compared to the risk they might be undergoing with the risk of bleeding and the risk of any iatrogen preterm delivery, you might consider, especially in the presence of an active sediments, presence of lupus, who might think that it could be a class 4 like was discussed, where it needs to have a different set of agents which needs to be used for immunosuppression. You might consider a patient to have a renal biopsy. So some of the things which you need to consider, that the proteinuria per se is not an indication for delivery. So if you have a heavy proteinuria, doesn't mean that the patient has to be delivered. Way back in 2011 or before 2011 or 13, the various guidelines used to suggest that if you have a proteinuria of more than 3 or more than 5, used to call as severe. And mind you, all throughout till this time, I never differentiated between severe and mild preeclampsia. This is one of the reasons is in the latest guideline which has come up in 2021, the term, they said that don't differentiate between a severe and a mild disease, because any lady who has a preeclampsia has got any time on an ongoing pregnancy, has at any time developing into any of the complications which can be even lethal. So the classification is restricted now to use of preeclampsia rather than differentiating them into a mild and a severe variety, or those with no severe features and with severe features. So edema is not helpful for diagnosis because pregnancy per se could be leading to various causes, including an anemia which leads to an edema, and the uric acid levels may have a restricted utility, especially in the presence of a CKD. A raised uric acid might point towards a development of a superimposed preeclampsia. So if a lady comes to you, like this lady who came to us with 12 weeks, you need to do a baseline evaluation to look out for the various characteristics which could point towards the presence of a preeclampsia. So you will look for a proteinuria. So anybody who is risk of development of a preeclampsia, you need to screen them with proteinuria, which could be a urine dipstick or a protein creatinine ratio, a complete blood count with a periphosmia, a renal and a liver function test, an ECG and echo based upon the characteristics and the duration of the hypertension, and a fundoscopy to rule out the presence of a hypertensive retinopathy. Now, how do I monitor and how do I follow up? So if you have just hypertension, no other endocrine damage or proteinuria, the patient could have once or twice BP which could be recorded way in her local peripheral health center if it is possible, or by the nurse which is visiting her at home. And if they have a severe hypertension, they need to repeat after 15 minutes and see the BP is persistent, and if it is so, the patient requires admission and then needs to have an evaluation. So the various investigation I mentioned needs to be worked up, and that needs to be done at least once in a week or once in 2 weeks. And the patient needs to have a fetal growth which could be scanned at around 28 weeks to screen for the development of a fetal growth restriction. And subsequently for the monitoring of the fetal well-being, either you can do a fetal biophysical profile, ultrasound-based biophysical profile, or do a cardiotrophic test. So how do I treat? Now, treating a preeclampsia, it's like a balance, right? So it is supposed to be an adaptive protective response. The high BP is a protective response rather than a disease in a pregnancy, because the BP is the one which actually let the push of the blood and the nutrients from the maternal side to the fetal side. So you're going to control the BP too tight, or you're trying to reduce it by too tight. The one who is going to suffer, you are going to protect the mother, but it may harm the baby by maybe leading it to have a small for gestation age, which might progress to have a severe growth restriction, which requires an early preterm delivery. So it has to be a balance between the mother and the baby when you are actually giving an antihypertensive. So for the chronic hypertension, the landmark study which changed the whole management was the CHIPS trial, which was done a multicentric trial which had 987 women with chronic, majority of them having a chronic hypertension, and they looked at whether the less tight, which is diastolic of less than 100, versus tight, which is diastolic of less than 85, is found to have useful. So one of the things, or the major finding of this study, was the people who has got a very tight control, when you keep it the diastolic of less than 85, is found to have lower rates of severe hypertension subsequently, right? But they didn't find a difference between the actual absolute numbers or the percentage or the proportion of patients who developed the severe maternal outcomes, which is in the term of eclampsias, abruptios, and the other various few complications. But they also had a subgroup, and this actually, the results what I'm showing here is actually based upon 3 or 4 papers, which also showed that in patients who has got severe hypertension, which is a marker irrespective of the presence of preeclampsia, that is going to contribute to the development of a various outcome. So ineffectively, they extrapolated saying that use of a tight control is better than a less tight control for a patient who has got a chronic hypertension to reduce the incidence of fetal-maternal complications. So when they did the tight control, the number of babies which were small went up marginally, but it was not significantly different between both the group. There was no difference not much significant difference between the groups which in terms of a NICU care. So they assumed that it is not, the composite outcomes is not much higher in patients who were on a less tight control, tight control compared to a less tight control. So looking at the various guidelines, what is the threshold at which we need to start an antihypertensive? Since the advent of the AHA guideline, which says about that when the BP is more than 130/90 to be called somebody to have a hypertension, all it says that the BP threshold of even the pregnant women came down. With the CHIPS trial, they extrapolated to all the patients with pregnancy, saying that 140/90 is a safe bet to start the patient on an antihypertensive. And the target of 130/85 is supposed to be the best one. So in effect, maintaining a BP of between 110 to 140 and anything at less than 85 diastolic is supposed to be the target for a patient whom we manage with a chronic hypertension in pregnancy. So this is specifically about the various guidelines about the chronic hypertension, which again shows that start antihypertensive. So for chronic hypertension, there is no doubt if a patient has a chronic hypertension, you need to start the patient on an antihypertensive when it is more than 140/90 and maintain it at less than 135/85. So I'm just showing a comparison between the recent one from the European Society of Hypertension, wherein they have stuck with the old diagnosis of 140/90 to call someone to have a stage 1, whereas the AHA has told 130/80 to be the hypertensive. And they said the BP, and both of them agree on one thing, that is if a patient is between 18 to 64, this is for non-pregnant, if that's way, the BP has to be maintained at less than 130/80 to reduce the incidence of complications later in life. So following the CHIPS trial, various guidelines changed management of chronic hypertension to saying that the target is to achieve a diastolic BP of less than 85. So anything, if it is less than 80, you need to consider to step down on the medications which is the patient is on, or you can stop the medication if it is maintained at that level, and if it is more than 85, you need to up-titrate the antihypertensive. The common drugs which is used for acute control of hypertension include the labetalol and nifedipine. There are various regimes, which is one of the common one is followed by the ACOG one, which is used in our labor room, and hydralazine is not available in IV preparations for us, so we used either nifedipine or labetalol to control the acute hypertension. And from the CHIPS trial, for a chronic hypertension, labetalol is the drug of choice. But shorter than, to complement that, you can use either nifedipine or methyl-dopa. But however, the methyl-dopa is not available in most of the settings because the production is not happening as it was happening before. So for the treatment of hypertension, this is one of the way to escalate. You don't have to go towards the much highest dose of a drug because that will be associated with a more incidence of complications. So you can go for a medium dose, add on a group of drug which is acting in a different way, which is actually going to achieve a much better control than going and escalating the dose to the maximum. So what are the maternal fetal complications of things? So like I discussed earlier, stroke, renal insufficiency, plastinal abruption and the postpartum hemorrhage seems to be much higher. Growth restriction and the preterm death remains a concern. So when we are counseling a patient, we need to take in their values and preferences, explain them about the hospital setting, because the NICU, sir was telling about NICU facility of having 28 weeks in his hospital, but for us it might still be a 30 weeks for a baby to go, and when the baby is of a weight of more than 1 gram. So you need to consider your NICU facilities, have a shared decision with involvement of the patient and the family when you go ahead. So in patients, if it is more than 37 weeks, you can proceed with a delivery, especially if it is in the presence of a superimposed preeclampsia. In the absence of a superimposed preeclampsia, the chronic hypertension could be taken even more than 38 weeks. Anytime between 38 to 40 is a time which is good enough to deliver those babies. So if you have a patient which is less than 37 weeks, but if you have a suspected abruption, has a rupture of membrane, abnormal fetal-maternal testing, and an estimated fetal weight suggests that it is a FGR baby, and the presence of various complications, you need to consider them to have an early delivery. There is no trials which suggest about which is the route of delivery which is to be used, but when we use a labor induction in these patients, especially in the presence of preeclampsia, try to reduce the time to the delivery, which is yet to be known that what's the exact cutoff at which we should call it a day. So I will just, okay. So looking at the long-term complications, so anybody who has a preeclampsia has a higher risk of development of various cardiovascular disease. There increases the risk of having a cardiovascular death, and even the baby also might be at increased risk of development of hypertension later on, and maybe obesity because of FGR and the fetal programming which happens in utero. So to summarize the case, she was continued on labetalol 200 mg 8th hourly, and she was subsequently added on nifedipine 10 mg 12th hourly. The baby was diagnosed to have FGR on fetal screening and was monitored with ultraviolet biophysical and the Doppler, and the maternal investigations were done as was told. Creatinine stabilized from 1.1 to maybe 0.9 and 1, and so we continued the pregnancy, and at 33 weeks we diagnosed that the Dopplers actually deteriorated, which mandated a delivery. So she was given steroids for fetal lung maturity, subsequently underwent cesarean section at 33 and 4 weeks, who delivered a baby of 1200 grams, which is again a severely growth restricted baby, and was shifted to NICU. And the mother's blood pressure remained normal with just continuing on nifedipine, because immediately after the postpartum the requirement might come down, and subsequently it raises at third to fifth day, and it remains plateau. So it was we were able to discharge the patient on nifedipine, and the creatinine was normalized, and we did the panels to look for what's the secondary hypertension causes. That was come to be normal. And later when the baby was discharged from the NICU, the patient was discharged and was asked to continue to look for proteinuria, because she had a massive proteinuria, which we need to look at whether she continued to have it, to look for further evaluation is required. So in summary, chronic hypertension, the incidence is increasing because of various reasons. One, the incidence of obesity is increasing, incidence of patients with metabolic syndrome is increasing, and because of the lifestyle changes or everything, so the hypertension is increasing in the community. So preeclampsia remains a multisystemic disease which has got a multifactorial in origin, and pregnant women with chronic hypertension needs to be evaluated just like another patient with a young hypertension, because they might have a long-term implications on those. If possible, rule out the causes of a secondary hypertension. The management to follow the CHIPS trial algorithm, so start an antihypertensive if it is more than 140/90, maintain the antihypertensives at less BP at between 110 to 140 systolic and less than 85 diastolic, and timing of delivery if it is with preeclampsia, anytime between more than 37 weeks you should consider, or earlier in the presence of other complication. Thank you.
Thank you, sir, for explaining this topic. After the CHIPS trial, it is clear that how we should treat on the basis of diastolic this blood pressure. So the thing is, chronic hypertension means before 20 weeks, and this patient after after delivery, the requirement of antihypertension decreased. So in a chronic hypertension with superimposed preeclampsia, we need to evaluate the cause for this hypertension. That is the most important point, and that's we should be doing after 6 weeks of postpartum, because there is a definitive cause for hypertension in this case. Young females with hypertension before 20 weeks means there is something related to either endocrine or kidney related disease. So that needs a further evaluation after delivery. That is the most important aspect. These patients are they are lost after delivery. They don't take care of themselves, and they again turn up after getting the next pregnancy. That is the biggest issue which we see in our general practice. And again, we are seeing the patient with a blood pressure of more than 160/90, and again the evaluation is not, it cannot be done. So this is the biggest challenge, and we should inform the patient that after 6 weeks or after 2 weeks, she has to turn up for further evaluation of her hypertension.
Yeah. So just to add on, the FIGO has come up with an initiative which is a postpartum initiative, which is actually bringing the MCH care with NCD. So patients, a group of patients like preeclampsia, gestational diabetes, obesity, those were actually supposed to be followed even after 4, maybe year or 2 after the pregnancy, because the higher the chance of development of a subsequent complication is within the first 2 years, and they sustain throughout the life. So they have started an initiative which is actually beneficial to link these two major things.
Because next time when they present, they present with some renal dysfunction also, some creatinine of 2.5 with a pregnancy. So we could not evaluate properly what would have happened during this time. So that is the biggest challenge we are facing.
Thank you, sir, for the excellent presentation. My doubt is actually regarding the follow-up of the patient. If the patient comes with hypertension the first trimester before 20 weeks, and will follow up liver functions and renal functions twice a week till once in 2.
Once a week or once in 2 weeks, based upon what is the presentation symptom. So
even if the patient is not having any proteinuria, also will follow up till.
Yeah.
And how often you find this non-proteinuric preeclampsia in a chronic hypertensive patient?
That is more common than a proteinuric hypertension, because most of these patients will have the one which is called as a suspected preeclampsia of having a hypertension with a headache or maybe a decreased urine output or this thing. But your labs may not find to be have a proteinuria in those patients, and you get admitted, and those patients might require a maxillary fundus liquid delivery. So we do get those patients who present with impending signs of preeclampsia. So the interesting fact of preeclampsia is, way back in 1600s, it's all started from a nephrology point of view. They found out that the patients were having seizures to have proteinuria. First they suspected it to be a Bright's disease which used to be there, and then they differentiated that there is going to be a prodromal stage or pre-stage which was called to be as preeclampsia. It was an eclampsia which was dissociated from seizure disorder because of the presence of proteinuria. And that's why hypertension versus proteinuria used to stand for a pretty long time, rather than having a multisystemic approach, which was only introduced maybe in 2005-2006 by the ISHP group and the Samans group.
Thank you so much, sir, for such an elegant talk, and thanks to the organizing team from Jipmer for having me here. I just have 2 questions. Supposing a lady presents beyond 12 weeks of gestation to us for the first time, are there any biomarkers in the pipeline which can differentiate superimposed preeclampsia from chronic hypertension? That is first. Second is that these days there's a theory that there's complement dysregulation behind essential hypertension. So is there any difference in the role of complement function or dysregulation in preeclampsia, superimposed preeclampsia versus chronic hypertension?
One is we diagnose someone to have a preeclampsia after the gestational age of 20 weeks. So we don't call someone to have a preeclampsia at less than 20 weeks, except in 2 conditions. One is a moral pregnancy, and the second one being a twin pregnancy, wherein these symptoms and even eclampsia can happen much earlier than the 20 weeks. Other than that, no patient is diagnosed to have a preeclampsia at less than 20 weeks. That's the first point. So the markers which we use in the first trimester, that's what I was trying to tell in the last talk, which ma'am was trying to say. There are 53 or 60 markers or biomarkers which has been tried out, of which two of the most prominent one which has been used in the first trimester. One was the PAPE, which tells about the placentation. So the values of values will tell you, there are two different cutoffs which tells you the chance of this thing, but that's also not an absolute one. The second one is the PLGF level, which is in combination with the clinical characteristics of the mean arterial pressure and the other clinical characteristics and the uterine artery Doppler, takes the sensitivity and the specificity to something beyond 70s. So, but it's again not 100% thing. It's still a work in progress at a combination. So there's no single marker or a marker which will differentiate someone who is going to develop a preeclampsia. But yes, the placentation you will get a clue by looking at the PAPE, which is done for a first trimester screening for aneuploidy, which is very useful. And if the patient can afford, because each test of PLGF will cost you around 1,500 to get it from a lab. We don't have facility here, so we ask for some selected group of patients to do it, and they have to do it with 1,500 to 2,000 rupees to do that test. So that will be helpful to tell you whether it's going to be helpful. So how does it help is in patients who has found to stratify based on these markers to have a high risk. And that's what's been done in the Western world, that they don't have a preeclampsia developing, because in patients who stratified to have a high risk, he started on aspirin, which I didn't cover on the prevention aspect. So you can, they say the patient, the latest one, which is in the SOMANS guidelines published last year, speaks about 115 patients who has got 150 milligram of aspirin in the night is going to have a 60% reduction of incidence of, 60 to 70% incidence of reduction of the preeclampsia, which can happen in pregnancy. So if you screen the patient and you are able to start the patient well ahead at less than 16 weeks with aspirin, the chance of she to progress to have a preeclampsia is much lower. Right? What was the second question? I'm sorry.
Role of complement dysregulation.
I'm sorry, I don't have much idea on those. But again, the whole thing of preeclampsia is moving towards the adult hypertension, saying that this is also a chronic inflammatory state rather than a separate entity which is happening in this thing.
The floor is open for questions from the audience.
No, just about the role of uric acid. Can we use that as a marker of preeclampsia anyway? It always goes up anyway.
It used to be, when I was a student, they used to say that look at the levels of uric acid, you can see that whether the patient is going to develop a preeclampsia, but it's not found to be as a marker, and neither it has figured in any of the guidelines to be as an important markers. Yes, it has some role in a patient who has an underlying chronic kidney disease, where if the levels are too high, then we can suspect that this is a patient is more likely to have an underlying superimposed preeclampsia rather than have a chronic kidney disease. Yes, it's available. It's available as a point of care test as well as a lab kits, which they can do it in the labs. But the cost of each person test, if you have to do it to get from a private lab, it is very costly at the moment.
Thank you, sir, for that wonderful discussion.
What is your take on the role of ABPM in masked hypertension pregnancy?
Actually, I'm doing some work on ABPM, so I'm yet to see the results. Maybe I would be able to tell you maybe next time. Thank you, ma'am.
Thank you, sir, for that wonderful discussion. We now request our chairpersons to kindly felicitate our esteemed speaker. Fernando to kindly hand over mementos as a token of appreciation to our chairpersons. Sir, please.
So we now move on to the last academic session for the day, which is on Peripartum Aki, the unwanted party mix of microangiopathic hemolytic anemia, renal failure, hypertension and oliguria. The session will be chaired by Professor N. Gopalakrishnan, who doesn't need any introduction to this crowd. He's a professor of nephrology and member secretary, Transtan. Dr. Raja Ramachandran, associate professor, nephrology, PGIMER, Chandigarh. And Dr. Swati Raju, assistant professor, nephrology, Jipmer, Puducherry. We invite the chairpersons onto the dais. We also invite our esteemed speaker, Dr. Susina Alexander, professor of nephrology, CMC Vellore. She is a distinguished alumnus of the same institute and went on to pursue her PhD in nephrology from Dr. MGR Medical University, Chennai. She is a recipient of numerous awards in the field of nephrology and takes keen interest in areas of genetics and glomerular disease. Madam, please, the stage is yours.
Good evening. I know this is the last session, so I'll keep it as short and sweet as possible, and it's going to be more clinical anyway. So I'll just read the clinical scenario that's been given. It's there in your brochures. The topic is Peripartum Aki, the party mix of MAHA, renal failure and hypertension and oliguria. It has already been announced. Before I begin, I would like to thank the organizers for giving me this opportunity and respected chairpersons and delegates. So just to read out the case scenario, it's a 24-year-old lady who underwent emergency LSCS for obstetric indication at 39 weeks. She developed oligoanuria with breathlessness over the next 48 hours. The lab investigations revealed anemia, worsening anemia, thrombocytopenia, and low C3. She had normal sized kidneys, and in view of anuria, hemodialysis was started. She underwent plex and dialysis, which was continued, and a kidney biopsy showed 60 to 70% renal cortical necrosis. So this is given in your brochure. Just keep this case in mind as you go through the presentation. Right, so though the title says Peripartum Aki, I'll be broadly covering pregnancy-related AKI, and anyway, Peripartum Aki is going to be a very important part of pregnancy-related AKI. Now, looking at the epidemiology, there is definitely a declining trend of pregnancy-related AKI, both in the developed world and the developing world. So in the developed world, over the decades, it has come to a very minuscule percentage. It is only about 0 to 1%. But in the developing country like India, it is still quite common. So we have a range of 5 to 20% of the total AKI population who present with pregnancy-related AKI. And overall, the most common pregnancy-related AKI is related to preeclampsia or HELP. This is a worldwide figure. But when you again, there is a discordance. When you again look at India or developing countries, it is septic abortion that comes up as a most common cause for pregnancy-related AKI. And the preeclampsia or the HELP is probably the third most common, because after that it is the obstetric complications that play a major role. So what do I mean by obstetric complications? This is like hemorrhage. So you can have placenta previa or abruptio placenta or some other like intrauterine death. These are the obstetric complications that can lead to pregnancy-related AKI. This is a report which shows the spectrum of pregnancy-related AKI in India over the decades. It also shows the spectrum of etiology across the decades. So if you can see in the screen, is there a pointer? Is there a pointer? Anyway, so if you can see on the screen, over the decades, the pregnancy-related AKI, the incidence has decreased, but it is still quite substantial, between 5 to 20%. And regarding, anyway, I can't see the screen. So, regarding etiology, there hasn't been much difference. Okay, so if you look at it, septic abortion still is a most common cause. And after that, it is obstetric-related complications which form the bulk of the pregnancy-related AKI. And then after that, of course, is the preeclampsia and HELP, and then comes the other diseases. Now, we all know that pregnancy, there are a lot of physiological changes that happen, and significant changes happen to the kidney also. Okay? So there is systemic vasodilatation, there is increased renal perfusion, there is increased filtration fraction, and there is increased GFR. So what does this mean for the markers that you do for assessing kidney injury? For example, the creatinine, which is in the normal range, is generally about 0.8 to 1.2. In pregnancy, it falls down to 0.4 to 0.5. So which means that if a pregnant woman comes with a creatinine of 0.8, then you need to diagnose renal impairment in her, and you should not assume that it is a normal creatinine. Even osmolality, because of the systemic vasodilatation, there is a stimulation of ADH, and ADH, it resets the osmolar threshold, and the new threshold in pregnancy becomes 270 milliosmoles. Now, even the bicarb, what happens to the serum bicarb is that there is a compensatory mechanism for the physiological respiratory alkalosis that happens due to hyperventilation. So more bicarb is released in the urine, and this leads to a drop in the serum bicarb level by about 4 milliequivalents. So all these changes will influence the way you use these markers to diagnose kidney injury in pregnancy. Okay, and even the other thing is proteinuria. Proteinuria, which is 150 milligram normal, which is a normal range in a non-pregnant adult, up to 300 milligram, it is normal in pregnancy because the filtration fraction increases and the protein secretion is more. Now, how do we define pregnancy-related AKI? There are a lot of bodies that have defined AKI in a non-pregnant adult, right? There's a Rifle criteria, there's a Akin criteria, there's a KDIGO criteria, but none of these things have been widely validated in pregnancy-related AKI. So in pregnancy-related AKI, the general consensus is if the creatinine is more than 1, or if there is a 50% increase from baseline over the last 48 hours, or if there's an accompanying oligoanuria or the need for RRT, you can diagnose a pregnant woman to have AKI. Okay, so when we talk about pregnancy-related AKI, you should not just focus on pregnancy. Okay, there are a spectrum of diseases that can cause pregnancy-related AKI. So the easiest way to classify this is classify it as those that are related to obstetric complications, those that are directly related to the pregnancy, to the fetus that she is carrying, and third is a miscellaneous, that you can even be hit with a dengue fever and have AKI. Okay, so as long as it is AKI in pregnancy, it will still be called pregnancy related AKI. Okay, so you'll have to think of 3 classifications going forward. Now in this, if you look at the first classification, that is the obstetric complications, septic abortion is a one that happens in the early trimester. So septic abortion is a commonest cause, and it is a commonest cause of AKI in the early trimester. So of course it is not a cause of peripartum AKI. All the other things that are mentioned below, the abruptio, the placenta previa, uterine hemorrhage, IUD, puerperal sepsis, all these are causes for peripartum AKI. Coming to pregnancy-specific disorders, these are disorders that happen when you have a gravid uterus. And these are preeclampsia, eclampsia syndrome, the HELP syndrome, the acute fatty liver of pregnancy, the TMA spectrum. All this can happen usually from the 3rd trimester to the postpartum period, depending on the etiology. And you can also have AKI due to a lot of other causes, right? You can just have a GN, like a lupus or a post-infectious GN. Or you can have just an infection, which can cause, or a hypovolemia, which can cause AKI. Now, another crucial clue to the diagnosis of what is the etiology behind this AKI will be the timing with respect to the gestational age. So septic we have already covered. All the others mostly become relevant during the late 2nd, 3rd trimester or immediate postpartum. A few differences that you can notice here is, especially TMA that is related to complement regulation. Usually, typically it happens in the postpartum period, whereas TMA of any other origin can happen anytime during pregnancy or postpartum. Acute fatty liver typically happens in the late 3rd trimester or just before delivery. Now, preeclampsia has been widely covered, and just suffice to say that there is preeclampsia that happens before 34 weeks has a higher risk for acute kidney injury than preeclampsia that happens more than 34 weeks. So, as has been mentioned previously, there is no term called mild or severe preeclampsia. We only say preeclampsia with one of the severe features. So, it could be either a thrombocytopenia or elevated liver enzymes and renal insufficiency. So, if you have renal insufficiency or AKI, you come under preeclampsia with severe feature. Now, what is the spectrum of AKI? How does AKI behave in preeclampsia? Now, out of all the preeclampsia, especially those with severe features, about 1% of them will be having acute kidney injury. And most of the preeclampsia happens antepartum, but it can also happen in the early postpartum period. Okay? And many times what happens is preeclampsia gets complicated by renal failure when there is usually an additional complication. Okay, and mostly it is an obstetric complication that happens. It could be hypovolemia related to placental abruption, or it could be DIC or IUD. About 15 to 20, so about 40% of the AKI in pregnant women worldwide and in India is due to preeclampsia or eclampsia. I'm not going into the detail of the histology. There is glomerular endotheliosis, which is a characteristic lesion. Usually in AKI, the commonest lesion that you find is acute tubular necrosis, but you can also have acute cortical necrosis. Acute cortical necrosis is the necrosis of the entire parenchyma or the renal cortex, which includes the blood vessels, the glomeruli and the tubules. So outcome per se in preeclampsia, generally if you deliver the fetus, there is a reversal of AKI. Okay? And so it is generally a favorable prognosis. So if you have a preeclampsia or eclampsia that is complicated with AKI, and if you could deliver the fetus, generally the prognosis to the kidney is good. Okay? If there is persistent renal dysfunction, that would also mean that there is an underlying, either he had a chronic hypertension which was superimposed with preeclampsia, or there was already some underlying CKD to begin with. That's a usual reason. Now, there is a very related syndrome to preeclampsia called the HELP. Some people think that HELP is a variant of severe preeclampsia or preeclampsia with severe feature, but HELP also has features that are very similar to TMA. So you have thrombosis, so you have MAHA, you have thrombocytopenia, and you have AKI. Usually HELP syndrome happens in the late 2nd trimester to 3rd trimester and early postpartum. And the most common symptom that the patients present with are non-specific, but the right hypochondrial or the epigastric pain is quite characteristic, and they can have other non-specific gastrointestinal symptoms like vomiting, nausea and headache. The other way in which HELP can present is with one of its complication. So just manifest, it could be that AKI is the first presentation for HELP syndrome, or one of the other complications like DIC or abruption, or pulmonary edema, or a hepatic capsular hematoma, retinal detachment. So the triad of HELP usually that helps you to diagnose this is the feature of MAHA, which is evident as schistocytes in blood smear or increased bilirubin or LDH, increased liver transaminases and thrombocytopenia. Usually HELP has this triad. Okay, so there is MAHA, there is, by the name of the syndrome itself, you will know there is hemolysis, there is elevated liver enzyme, and there is low platelet. What about AKI in HELP? AKI in HELP is more prevalent than just preeclampsia with severe feature. It happens in about 15% of cases, and there is requirement for dialysis, but just like preeclampsia, the prognosis for the kidney is generally good in most of the cases. Okay? And the progression happens only if there is usually it's seen only in less than 10%. And only less than 10% of the kidney biopsies show a feature of TMA. So just like severe preeclampsia, HELP also, the recovery of renal function is generally good. Now just comparing and contrasting the complications between severe eclampsia and HELP, AKI is more common in HELP. DIC is comparable, the disseminated coagulopathy can happen in both. Pulmonary edema, placental abruption are more common in HELP. And perinatal mortality is much more in HELP. Okay, the perinatal mortality again depends on the severity of the illness, and the very fact that the patient has AKI increases the perinatal mortality. The maternal mortality is around 1%. Now coming to another pregnancy-related disorder that can manifest as AKI, MAHA and thrombocytopenia is the acute fatty liver of pregnancy. Now when you hear this term acute fatty liver of pregnancy, you should know it is an obstetric emergency. Okay? So AFLP, when you hear the diagnosis AFLP, know that it is an obstetric emergency. There are two crucial manifestations for this. One is severe coagulopathy, the other one is fulminant liver failure. So you need to intervene fast. Okay. And AFLP usually happens in the 3rd trimester of pregnancy, and the treatment for AFLP is delivery of the baby. Okay, you deliver the baby and you have taken care of AFLP. What is AFLP? Generally, it could be an genetic disorder, but there is a defective function of this 3-hydroxyacyl coenzyme dehydrogenase. So what does this do? This has a defective, the mitochondrial fatty acid beta oxidation becomes defective. So when that becomes defective, there is accumulation of fetal fatty acid. The fetal fatty acid then comes into the maternal circulation. Once it comes into the maternal circulation, it enters the liver. And once it enters the liver, it causes the severe liver injury. That is why when you do the liver histology, when you see lipid microvesicles, it is characteristic of this disease, and there is absence of inflammation or necrosis. This is one way you distinguish this from another common hepatitis in pregnancy, which is viral hepatitis. Because in viral hepatitis, there's a lot of inflammation and necrosis, whereas in this, there is lipid microvesicle infiltration, but there is absence of inflammation or necrosis. Again, the early symptoms of this is non-specific. You have fever, nausea, vomiting, abdominal pain. But with progression, it will the patient will have jaundice and hepatic encephalopathy. Coagulopathy is a very important feature of acute fatty liver of pregnancy. So you will have low fibrinogen, you will have prolonged APTT, you will have low antithrombin levels and platelets. Whereas coagulopathy is not very common in the TMA spectrum of diseases. And you will have liver dysfunction. The other two characteristics that will help you distinguish between these is the presence of hypoglycemia and leukocytosis. The incidence of AKI and AFLP is quite varied, but it's mostly mild and non-oliguric, and it's multifactorial. Usually it can be caused by hypovolemia, it could be because of the coagulopathy or because of hepatic failure or hemorrhage. And in most women, once you deliver the fetus, there is immediate, there is complete liver and kidney recovery. Now coming to another pregnancy-related, a pregnancy-specific disorder that can cause AKI, MAHA and thrombocytopenia, it is a thrombotic microangiopathies of pregnancy. This can occur any time, but it can either occur in the first pregnancy Usually, it is seen in the successive pregnancies, but it could occur. It's not that it can't occur in the first pregnancy. It can be a de novo occurrence. It can be a relapse during pregnancy. That is, you would have had a TMA episode and now you're pregnant and you're having a relapse of TMA. Or it could be recurrent with subsequent pregnancies. Pregnancy-associated TMA accounts for 20% of all cases of TMA. So again, this can be three groups. One is the TTP, which is due to ADAMTS13 deficiency. The other is dysregulation of the complement pathway, and then an unknown mechanism. Now coming to TTP, the distinguishing feature here is the presence of neurological symptoms. Okay, everything else is similar, but you have more of neurological symptoms in TTP and less of kidney impairment in TTP. Usually diagnosed before delivery. There is a role for monitoring ADAMTS13 level, especially to identify patients who are at risk of developing this TMA relapse. And there are some studies which have shown that the prophylactic treatment using Plex to increase the enzyme activity of ADAMTS13 and keep it more than 10% may be helpful, but it's not, there hasn't been any well done controlled studies. Coming to complement-mediated TMA, this is also, the spectrum is the same, but neurological involvement is less and kidney injury is more. Okay, the previous one, neurological involvement was more and kidney injury was less. This typically complement-mediated TMA can occurs postpartum up to 6 months. And complement dysregulation can be evident in up to 80% of cases. Just because you cannot see complement dysregulation, you are not able to diagnose, that doesn't mean that it is not complement mediated TMA. Infections and bleeding are a major trigger for this, and factor H and factor I, either the deficiency or antibodies can contribute to it. This is one pregnancy related AKI where renal recovery is not good. Okay, we talked about preeclampsia, we talked about HELP. All this I said that generally the kidney recovery is good, prognosis is good. We talked about AFLP and we said once you deliver the baby, the kidney recovery is good. But this is one such case where if you have this and if you have AKI, then the kidney recovery is not very good. Or many of them end up in end-stage kidney disease. Okay. And you can even risk stratify, like if anybody is have had a TMA and who is planning a pregnancy, you can look at their genetic studies and then give them the risk of TMA in their pregnancies depending on the mutations. Again, to compare and contrast, just to recollect and jog your memory, preeclampsia and HELP usually in the 3rd trimester. TTP again pre-delivery. Complement-mediated TMA is typically late 3rd trimester or postpartum, and AFLP is 3rd trimester. The other distinguishing features you should know is renal, coming to hypertension, more common in HELP and AFLP. Renal prognosis, not good in HUS, and ammonia levels can be very high in AFLP because they come with hepatic encephalopathy. Now, clinically, distinguishing AFLP from HELP syndrome. Now, this may not be of that importance because the treatment for both is delivery of the baby. Okay, so it is sometimes quite difficult and challenging to distinguish between the two. But since the treatment for both is delivery, it may not be it may be just of an academic importance sometimes to really threadbare distinguish between the two. But and also you should remember that 50% of patients with AFLP can have concomitant P, okay, preeclampsia. Some of the clinical clues which could help you distinguish between the two. One is severe coagulopathy and hypoglycemia happens in AFLP, not common in P. there's profoundly depressed antithrombin level and severe liver dysfunction in AFLP, and thrombocytopenia is generally mild here, whereas it is severe in preeclampsia or HELP. What about distinguishing TTP, HUS and HELP syndrome? Now this, it's a little tricky, because in TTP, HUS, delivery does not really help improve prognosis. In TTP, HUS, you are giving Plex to treat it, and you can even give complement inhibitors, and you can carry on with your pregnancy, right? If there is improvement of the biochemical parameters. Whereas in HELP, it is the other way around. In HELP, you need to deliver the baby. So in this situation, it is a little tricky, and it is important to distinguish between the two as far as possible. Again, sometimes it is not clinically feasible. Both have MAHA, thrombocytopenia, renal disease. We should also know that about 20% of patients with TMA can have concomitant preeclampsia and HELP. And if they have a concomitant preeclampsia and HELP, the maternal mortality is very high. Certain clinical clues that may help you distinguish between the two is related to the coagulation abnormalities. Again, in HELP, in TMA, we don't expect coagulation abnormalities, whereas in HELP, you can have elevated levels of D-dimer, elevated levels of antithrombin, or high fibrinogen levels. Isolated LDH increase with normal hepatic enzyme, again, is in favor of HUS or TTP, whereas in HELP, you will have, classically, you will have elevated liver enzymes. And the other way around if there is increased liver enzymes. Now, how do you treat acute kidney injury in pregnancy? Supportive measures are the same as for a non-pregnant adult. You need to make sure that they are given good IV fluids, because hypovolemia can not only decrease renal perfusion, it can also have an influence on uteroplacental perfusion. You should make sure that all the metabolic complications are addressed. Control hypertension. Again, controlling hypertension, the drugs have already been mentioned. ACE, ARBs are not recommended. Drugs like labetalol, drugs like calcium channel blockers or methyl dopa are the preferred ones. Coming to dialysis. Dialysis, again, the indications for dialysis same as in a non-pregnant adult. But generally we recommend early start of dialysis. Okay, this is because, and frequent dialysis. So you should have at least 20 hours of dialysis per week. This is and mostly daily dialysis, mainly because you want to avoid hypokalemia related to prolonged dialysis. You want to make sure the metabolic parameters are as near normal for as long duration. Otherwise, it will have consequence on prematurity, polyhydramnios, and fetal growth. Intermittent hemodialysis is a preferred choice, and keep the metabolic parameters in the narrow range as far as possible. Preeclampsia and HELP, these are pregnancy-specific treatments. In preeclampsia and HELP syndrome, before 24 weeks, generally if there is a severe feature in AKI, pregnancy discontinuation is recommended. Between 24 to 32 weeks, it's expectant management, and after 32 weeks, delivery is the treatment of choice. But in case there is any worsening maternal condition or fetal compromise, then there is no role for expectant management. There is a report that removal of SFLT from circulation using apheresis has improved proteinuria and helped in prolongation of pregnancy. Again, this is just one report, it is not a controlled study. Acute fatty liver, urgent delivery, glycemic control, and treatment for hepatic encephalopathy. In pregnancy-associated TTP, you go with FFP infusion of Plex, and if it is autoimmune, then you give immunosuppression. In pregnancy-associated atypical HUS, the optimal treatment is definitely eculizumab, but since most of us do not have access to that drug, the most commonly used treatment is plasma infusion and plasma exchange, and the renal recovery is not very good. Please remember the
Reminder for the
obstetric.
timing.
Yeah, it's only 2 slides. Obstetric causes for acute cortical necrosis, where with continued dialysis, at least 20 to 40% of patients can have partial kidney recovery. So take-home messages are pregnancy, preeclampsia, eclampsia is the leading cause for pregnancy-related AKI, whereas it is septic abortion in India. A validated definition for AKI is not established in pregnancy. Early dialysis of at least more than 20 hours per week is recommended if they have, if they require it. And even cortical necrosis can have 20 to 40% of them can have partial renal recovery. Thank you.
Thank you, Professor Alexander. We can take any questions? 1 or 2 questions? Okay, thank you. So you said septic abortion is the most common cause of acute kidney injury in India, but is it still valid? I think it's almost non-existent. Non-existent means it's to the aisles. Second one, what do you think? Let me complete. The second one is regarding thrombotic microangiopathy. Do you really believe that thrombotic microangiopathy is only 1 per 1,000 cases or something like that? Do you believe that kind of a data?
Yeah. So when I meant what I meant by septic abortion is septic abortion and puerperal sepsis. Okay. So it is not just septic abortion. I apologize for that, but it is septic abortion and puerperal sepsis. We still do see a lot of puerperal sepsis with retained products of conception. TMA incidence, I'm really not sure what's the true figure in India.
I feel that it's probably underestimated because most of the times it's reported by people who are not aware of that.
Very good lecture. Since the clinical scenario mentions about hypocomplementemia, a word about that. It's hypocomplementemia, right? Yeah, actually. Yeah. So hypocomplementemia, whenever you come across, either it can be atypical HUS, where there is alternate pathway complement activation resulting in hypocomplementemia. At the same time, in this scenario, when it happens in the peripartum period, one should not forget SLE flare. Lupus can make its presence for the first ever time just after pregnancy. And the biopsy revealing cortical necrosis again does not rule out lupus here, because lupus associated hypertension, there can be superimposition of TMA and that can lead on to cortical necrosis as well. And whenever I learn about obstetric AKI, there are a lot of the semantics and the nomenclature that used to threaten me as a registrar. Then later on, a couple of wonderful articles came up a decade ago that cleared the cloudy nature of the nomenclature in this arena. I don't know whether you agree with the nomenclature in pregnancy. Normally in non-pregnant situation, when you say a thrombotic microangiopathy, we very loosely interchange that with the atypical HUS. Whereas in pregnancy, there are articles like thrombotic microangiopathies of pregnancy, which is a broader term that encompasses 3 important entities. One is the atypical HUS per se, then the health variant of preeclampsia, and the AFLP. Why is it so? Because in a given patient, all the 3 can be there, and an element of each one of these things can be there. One common perturbation that is happening in all these entities is endothelial injury. Need not be physical injury, a profound endothelial dysfunction. So, whereas we have to be careful not to use TMA with any other connotation in a non-pregnant state. You agree with this point, actually? Pardon me? Yeah, the thrombotic microangiopathies of pregnancy. They say it's a broader term with these 3 entities, like the health variant of the preeclampsia, the AFLP, and the classical atypical HS.
So there are reports where they have said that HELP is a spectrum of TMA itself.
Exactly.
And there are reports where they have even shown complement dysregulation in
exactly. I mean, now the more and more evidence is accumulating that all these long days we have been taught that HELP is a very severe form of preeclampsia, but probably it may represent a totally different disease entity. There are enough reasons to believe in that. And again, in MMC series also, the sepsis is the most common cause for AKI. Septic abortion hardly ever we see now. When I was a registrar, we used to get sepsis. Yeah, that's right. It is, and again, acute pyelonephritis. We do come across very complicated UTI ending up in even dialysis requiring acute kidney injury in the pregnancy setting and so on. And a word of caution is that, like all these AKIs, even subtle forms of AKI, definitely they have to be followed up in the long term because they all have a very high potential to go in for CKD. The simple reason is that what apparently looks a pure, simple acute tubular necrosis in the kidney biopsy, there can be a kind of a sample error. There can be patchy cortical necrosis because pregnancy being a procoagulant state, there are a lot of microthrombi and clogging the microcirculation, a very subtle, smaller foci of cortical necrosis, and which have the propensity to degenerate into CKD later life. Thank you. That was a wonderful lecture.
Thank you, ma'am, for the enlightening discussion. We now request the chairperson to present the memento to the speaker. We request Dr. Satish Balan to kindly present the memento to the chairpersons. Following this, we'll be having the paper presentation and quiz session. Delegates who are participating in the quiz session are requested to go to the first floor, and the remaining delegates and the faculties are requested to remain here for the paper presentation. Thank you. We request the three presenters for the paper presentation session to come to the dais, come to the desk. Dr. Yashendu, Dr. Deepa, and Dr. Apurva.
That was indeed an academic feast. Having concluded the academic sessions for the day, we now proceed to paper presentation and the quiz session, which will be chaired by Dr. Edwin Fernando, Professor and Head of Nephrology at Stanley Medical College, Dr. P.S. Priyamvada, Professor of Nephrology, Jipmer, Pondicherry, and Dr. Susina Alexander, Professor of Nephrology at CMC Vellore. We also call upon the participants onto the stage. The first presenter of today's paper presentation would be Dr. Yashendu, Senior Resident of Nephrology from SGPGI Lucknow. Kindly come on to the stage, sir.
This is working.
So for the kind attention of those who present the papers, you'll be given 8 minutes for the paper presentation, and kindly stick on to the time because we are already running behind.
So good evening everyone. So I'll be presenting the first paper today, which is basically the histopathological and clinical characteristics of biopsy-proven pregnancy-related AKI, a single-center study from SGPGI Lucknow. By now we know that pregnancy-related AKI represents a significant challenge, and it is characterized by significant decline in renal function, which leads to severe maternal and fetal complications. The incidence of Aki, though it had come down from past, is still a concern because our female patients are not accessed to tertiary care center at the right point of time. Studies till now have indicated that timely recognition, diagnosis, early management can significantly impact maternal, fetal, and renal outcomes. However, there is a dearth of literature studying the etiology, histopathological diagnosis, the therapy, and the outcomes received. So I would like to my first aim would be to identify the clinical characteristics and precipitating factors associated with the development of pregnancy-related AKI, analyze the biopsy findings of the same set of patients, to study the patient and renal outcomes of the patients, and what are the factors associated with non-recovery in such patients. So it was a retrospective observational study conducted from 2015 to 2023. Out of 520 patients of pregnancy-related AKI, biopsy-proven pregnancy Aki was identified, which was 186, out of which patients who had fulfilled the inclusion criteria of 161 patients were included in the study. So patients were of age more than 18 years, and patients had a renal biopsy with complete medical records. Pregnancy in a renal transplant recipient or patients who had prior history of renal disease, CKD or diabetes were excluded, and patients with a follow-up of less than 6 months were excluded. So coming to the baseline data, so the mean age of the population was 34.7 years, which is slightly on the higher side as compared to the other studies published. Around 46% of the patients were primi and 54% of the patients were multigravida, which was varied from 1 to 7 pregnancy. The primary mode of delivery was LSCS, seen in 67% of patients as compared to 32% patients who underwent vaginal delivery. The chronic hypertension was seen in 5.6% of patients, and preeclampsia was seen in 9.8% of patients. The diagnosis of pregnancy-related AKI was made in the first trimester in 4 patients. In second trimester, there were 16 patients who were diagnosed with pregnancy-related AKI. In third trimester, there were 8 patients. However, the major chunk of patients were in the postpartum period. That was around 82.6% of patients. The predominant presenting symptoms were decrease in urine output, which was seen in 87.5% of patients, and anuria was noted in 68.3% of patients, and fever was seen in 58.3% of patients, and other presenting symptoms are mentioned here. The most common precipitating factors was sepsis, which was seen in 52.2% of patients, hypertension seen in 32.3% patients, followed by postpartum and antepartum hemorrhage. The baseline laboratory variables showed anemia with hemoglobin of 8.2. Creatinine at the baseline at the time of diagnosis was 6.82. However, the liver enzymes were normal. LDH, the median value was 1.2 thousand, and cystocytes or evidence of microangiopathic hemolytic anemia was seen in 42.8% of patients. So the autoimmunological workup, I think one table is missed. So that complement level were normal, ANA was positive in 10 patients, and dsDNA was elevated in 1 patient. At the admission, the dialysis requirement was seen in 93.8% of patients, that was almost 151 patients, out of which 21 patients had received steroids or a combination of steroids and Celcept, 35 patients had received plasmapheresis, 21 patients had received plasma infusion, and anemia requiring blood transfusion was seen in 65.8% of patients. The etiology of Praki in our cohort, most common was sepsis, which was seen in 42.2%, which included septic abortion as well as puerperal sepsis UTI. They are followed by pregnancy-related HUS, which was seen in 29.2% of patients, followed by obstetric hemorrhage seen in 16% patient. Hypertensive disorder of pregnancy leading to Praki was seen only in 2 patients. Lupus nephritis was seen in 1 patient, and 17 patients had other glomerular disorders. This is just to show that the biopsy findings, out of the whole cohort, 89% of patients had acute cortical necrosis, out of which 72 patients had patchy cortical necrosis, 17 patients had complete cortical necrosis. TMA was seen in 45 patients, which comprised 27.9% of patients, followed by acute tubular necrosis seen in 9 patients. DGGS with TI and probably a part of reflux nephropathy was seen in 6 patients. DGGS was seen in 5 patients, and mesangiopolytic glomerular nephritis was seen in 3 patients, out of which 2 were diagnosed to have IgA nephropathy. Third patient had immunofluorescence, which was negative. 3 patients had FSGS and 1 patient had lupus nephritis. All the biopsies were performed after a removal of delivery of product of conception, and renal biopsies were performed at a mean duration of 12 plus minus 7 days. The median follow-up was around 11 months. Coming to the patient outcomes, 15 patients had death during the follow-up period. 7 patients underwent transplant, out of which 2 patients had thrombotic microangiopathy, and remaining patients had acute cortical necrosis. Coming to the renal outcomes, as I told, 93.8% of patients at admission had requirement of dialysis. At 6 months, almost 21 patients had recovered and only 130 patients required dialysis. At the last follow-up, the patients, almost 105 patients are still on dialysis. Coming to the recovery, renal recovery, 34 patients, that is 21.1 patient, had shown either partial or complete recovery, and 127 patients had no recovery till now. Coming to the fetal outcomes, live birth was seen in 74.5% of patients, intrauterine death was seen in 13% of patients, and abortion was seen in 20 patients, which was predominantly first and second trimester. So while comparing both the groups, the recovery and the non-recovering group, as we see, there was no significant difference between the age or the parity. However, what we noted that patients who had undergone vaginal delivery were higher in the non-recovery group, and the value was statistically significant. Subsequently, chronic hypertension was also not significant between the groups, but preeclampsia, though the numbers were same, but it was much more commoner in the recovery group, and as ma'am had just told, that preeclampsia usually causes a milder form of AKI. While seeing the onset of pregnancy-related AKI, we saw that during the first trimester, though the numbers are quite less, 3 and 1, patients who had diagnosed to have pregnancy-related AKI during the first trimester had shown more recovery, and as we know, during the postpartum period, the major chunk of the patients had shown no recovery. The 3 most common presenting symptoms, fever and anuria, was more common in the non-recovering group. Other precipitating factors were not different. Hemoglobin, TLC, platelets were not different. However, creatinine at the time of presentation was significantly higher in the non-recovery group, and at the last follow-up, creatinine was 1.81 in the recovery group against 6.98 in the non-recovering group. Even the albumin levels were lower in the non-recovering group. Coming to the fetal outcomes, live fetal outcome was seen more in the non-recovery group. This, the probable explanation is that these patients, major chunk of patients had presented during the postpartum period. So by that time, the pregnancy was uneventful. Coming to the histopathological differences, cortical necrosis was associated with no recovery, and ATN was associated with recovery, which was statistically significant. As I told earlier, the majority of the patient, 93% of patients required dialysis at the presentation, and the major chunk were in the non-recovering group as compared to the recovery group. While comparing the therapy, what they had received.
Dr. Yashinder, you are approaching your time limit. Please wind up in next 30 seconds.
Yes, ma'am. So coming to the therapy, patient who had received steroids and MMF were shown recovery as compared to other group. However, plasmapheresis or blood transfusion did not show any recovery. So as other studies have showed, fever, anuria, and elevated creatinine with low albumin and dialysis requiring renal failure at the time of presentation are associated with poor outcome. This was also shown in a study published from Madras Medical College. But on biopsy, cortical necrosis and ATN was associated with cortical necrosis had poor prognosis. However, ATN showed recovery. 21 patients became dialysis independent at 6 months. Yes, ma'am. So to sum up, whether renal biopsy is really required, yes, the answer is yes, because in such patients who present with advanced renal failure, we need to establish the diagnosis and then guide the treatment. Secondly, we need to prognosticate the extent of injury, and especially in a patient who has unexplained renal failure and non-recovery renal failure, biopsy should be done. As we know that these set of patients have poor outcomes, and the chances of recovery in such patient is poor, so early diagnosis, prompt referral, and timely management is of utmost importance. Thank you.
Any questions from the audience?
Wonderful work. Thank you. My only question to you is, in patients with cortical necrosis, did the pathology look for TMA? Because it could be possible that it's all
actually, there were two things simultaneously going on. One was the clinical diagnosis and one was the histopathological diagnosis. What I have mentioned here is the pathological finding. Like in cortical necrosis, the histopathology looked like a frank cortical necrosis, whereas in thrombotic microangiopathy, we had features of fibrinoid necrosis and mesangiolisis. So there is an overlap between the same, sir. So it is the clear-cut demarcation is little tricky, and based on the time when the biopsy was done from the onset of injury can also alter this.
Yeah, it's really tricky. Cortical necrosis, the mildest form of cortical necrosis can be missed in a kidney biopsy,
yes,
and sometimes what you see will be ATN.
Yes,
the worst case scenarios, you will see the mildest form of TMA, you might see it as ATN. The worst TMA, you're going to see it as cortical necrosis. So that's the issue.
Yes, ma'am.
You didn't mention what was the diagnostic criteria you used for identifying the cases.
Ma'am, the diagnostic criteria used was, we had used the AKI for the standard AKI definition, either decrease in urine output or a rise of creatinine of more than 0.3 from the baseline value. Yes, KDO, yes, ma'am.
Can you just repeat the title of your presentation?
Histopathological and clinical characteristic of biopsy-proven pregnancy-related AKI.
Okay. Because generally when you say biopsy-proven, you're looking at a severe spectrum anyway, right?
Yes, ma'am.
You're not looking at the milder spectrum.
Yes, ma'am. That's why we have done the biopsy.
So what proportion of pregnancy-related AKI patients did you offer biopsy? Were you able to do biopsy?
Actually, we had almost around 560 patients during the study period, ma'am. Out of which we had performed renal biopsy. We had biopsy in 186 patients. But as per our inclusion criteria, only 161 patients fitted into the criteria. So we went ahead for the analysis.
What is your explanation for vaginal delivery as a factor that is associated with the non-recovery of kidney function? You have any explanations for that?
Maybe in a, like, ma'am, in our country, maybe indigenous methods and use of home delivery and the more chances of puerperal sepsis can be one explanation which can be given because these patients had more chances of AKI.
Okay, see whether those patients, like you had a significant proportion of IUDs also, right?
Around 20 patients, yes,
Yeah,
ma'am.
that sometimes might be
Yes,
the
ma'am.
explanation.
Yes, ma'am.
Because the fetus is already dead and there is no compulsion to make the delivery early, and if at all you do it, that's only for maternal indication.
Yes,
So sometimes this actually might be, it might not be the actual factor, there might be a confounding variable behind this finding.
Yes, ma'am. Thank you.
So if there are no more questions, okay, thank you. It was, Sabri has a question.
Yes, sir.
A patient sustaining a road traffic accident, he bleeds so much, but the AK will be mild. They don't develop cortical necrosis.
Sir,
why the patients of postpartum AKI due to postpartum hemorrhage, they bleed almost like, even if it is 1 liter, they may have a higher chance of developing cortical necrosis.
Sir,
Why is it
actually,
so?
there was an experiment performed in rats, sir, where they had found there is a phenomenon called as Schwarzschild phenomenon, where usually the pregnant patient had more chances of endothelial injury with the same level of endotoxicemia. Secondly, pregnancy is already at a state of maximum compensation, sir. So if at that point of time another injury is done, so
for a pregnant lady, because after fighting all the adversity, CKD woman having chances of pregnancy, it is a very dareful situation to get a pregnant and follow the consequences of after renal transplantation pregnancy consequences. So it put a very heavy weights on the nephrologist to having this kind of to tackle this kind of situations. So I will quote a famous quote by Lance Conard: I can imagine no heroism greater than the motherhood. I will present a single center study done at SGPGI. Before that, I will, in the introductory part, disruption of the hypothalamic and pituitary gonadal axis leads to the impairment of fertility in the patients of renal failure. Women, pregnancy rate is rare, very rare in the dialysis patient with a very low incidence of conception, around 0.9 to 7%. CKD will lead to leading to very different reproductive differences as for the maternal aspect. Firstly, the hypogonadal and hypothalamic gonadal and axis disruption, there is infertility, which leads to further pregnancy, very less chances of pregnancy, and there will be a rapid deterioration of renal function when a woman of the CKD has conceived. There will be an increased number of complications in the peripartum period with increased morbidity and mortality. For the fetal aspects, there will be a high chances of fetal growth restriction, preterm labor and fetal anomalies. After having kidney transplantation, it offers the best optimistic belief to women with end-stage renal disease who wishes to become a pregnant. In pregnancy, beside the teratogenic effects of some immunosuppressive medication, there is a risk of rapid deterioration of the graft. So the essential part of the transplant counseling should contain preconception counseling, family planning and contraceptions. So the study, my study includes all the female kidney transplant recipient between January 2010 to January 2024 who were followed on our transplant OPD. Patients who become pregnant in the post-transplant period were included in the study. Details were retrieved from our electronic medical systems. Total 215 women underwent kidney transplants, out of which 11 had got pregnancy, and which was 5.1%, with having 9 live births postpartum period and followed. The mean age of the recipient was around 28.6 years. All the patients were 11 patients were underwent of ABO compatible transplantation, with 6 receiving ATG as induction, 3 patients receiving basiliximab, and 2 patients didn't receive any induction due to low immunological risk. Out of 11 patients, 7 patients were on antihypertensive, and one is having post-transplant diabetes mellitus. No patient has experienced any previous history of rejection before pregnancy. 10 patients were maintained on the immunosuppression on tacrolimus, prednisolone, and mycophenolate mofetil was changed to azathioprine before pregnancy, and 1 patient was changed from everolimus to azathioprine. So the baseline characteristic was suggestive that the mean age at the time of transplantation was 25.8, and the mean age of the pregnancy was 28.6 years, which was giving the difference of around 3 years after post-transplant. Mean age was there. Donors were majority of the donors were father. Baseline serum creatinine of the pre-pregnancy level was 1.22. In the form of comorbidity, as previously described, 7 patients were hypertensive and 1 patient is having PTDM. So the before pregnancy, the mean duration of the change of immunosuppression was 5.2 months. So the mean duration of the pregnancy was 31.8 weeks, which was suggestive of all the majority of the patients were having preterm labor. 7 were chronically hypertensive. 3 patients were having preeclampsia, and 1 patient having criteria diagnosing as eclampsia. 4 patients underwent LSES due to maternal and obstetrical indications, and 7 underwent under normal vaginal delivery. In terms of fetal outcome, one patient is having spontaneous abortion at the 20 weeks of the pregnancy, and 1 has IUD at the 36 of weeks of pregnancy. 5 patients fetuses has experiences IUGR, and 7 preterm delivery was delivered out of 11. So the mean serum creatinine level was at the baseline was 1.22. Within the postpartum period, at the 3 months it was 2.01. At the 6 months it was 2.21, and at the 12 months it was 2.87. The mean 24-hour proteinuria from baseline was 0.76 grams per day, and at the 12 months of has experienced graft dysfunction, out of which 4 has lost her graft, and stable graft functions were in the remaining 5 patients. Time of the graft loss was median for 9 months, and the causes of graft loss was delineated as the biopsy proven ABMR in 2 patients, TCMR in 1 patient, borderline cellular rejection in 1, and mixed cellular rejection was 1. This was the comparative study between graft loss and which has having preserved graft, which was having significant indicators was significant p-value in the form of who was having higher the baseline proteinuria was high chances of graft loss, and need of antihypertensive drugs was in which patients were higher, they have more likely to having graft loss. And the post-transplant rejections were favoring the higher chances of graft loss. So in discussion part, in our study, as stillbirth and abortion was present in 1 pregnancy each, all other data also suggest normal risk as compared to the general population. Normal spontaneous birth rate was lower, and the risk of preterm delivery is high, with high rate of the gestational hypertension, preeclampsia, and IGR. More common in the kidney transplant recipients. Graft functions may be affected negatively in the pregnancy experienced, and kidney functions should be monitored more closely in the patient pregnancies. So to summarize these patients, in our study there are significant prognostic markers as baseline graft function, pre-conception proteinuria, hypertensive control during pre-pregnancy period, prevalence of superimposed preeclampsia, and postpartum graft rejections. So the take-home message is that for a better outcome for pregnancy in a patient of renal transplant patients, ideal time of transplantation is at least should be 1 year after the transplantation. There should be a stable graft functions, and creatinine should be less than 1.5 milligram per dl. Well-controlled blood pressures, BP should be less than 140/90, and proteinuria should be less than 500 milligram. And we have to stop the MMF and mTOR 6 weeks prior to the conception. Thank you.
Good presentation.
We have to stop immediately when at the time of diagnosis of conception, pregnancy, and we should closely monitor for at the time of organogenesis, which was around 18 to 20 weeks of pregnancy, and following regularly with 2 weeks of ultrasound.
So the majority of your patients conceived without proper planning?
Unplanned.
So did you look at the outcomes between these two groups, between the planned pregnancies
basically
and unplanned?
Patients are, we usually counsel every female woman patients during pre-transplant counseling about the conceiving and all the things. But if they are unplanned due to poor contraceptions provided, that poor barrier methods and all the things, and maybe sort of some non-compliance to the treatment of immunosuppression after the pregnancy or delivery, that may be a leading cause of that.
So how many of them, the pregnancy was detected at what gestational age on an average for these women?
Sorry,
was it early pregnancy, or did they come late in their pregnancy to the nephrologist?
So, actually, ma'am, in transplant OPD, we follow every patient, and if there is amenorrhea, usually the reproductive hormones and the cycles were resume its normal cycle after renal transplant 6 months after that period of that. So, any newly detected amenorrhea will trigger that lady, and usually that may come to us around 4 to 6 weeks of the.
No, so most of them were detected early in the early trimester.
Yes, ma'am.
So you would have given counseling regarding the high risk nature of the pregnancy in most of your patients, right?
Yes, ma'am.
How many of them would have accepted not continuing with the pregnancy?
No one, ma'am. No one.
She didn't realize that she was pregnant. And when she had the beginning, that was the first time she realized that she was pregnant.
Presenting your data. This has been our experience also. Like, should we, instead of playing it low, should we boldly say that we discourage pregnancy in all the patients? Like, if you were considering 50%, our data is even horrible. So should we really strongly say that we discourage pregnancies in patients who are transplant recipients?
Yes, sir. It leads to graft loss and. Yes, sir. We should discourage, but in Indian scenario,
it's not that discouraging. You have to carefully select patients for pregnancies. Not really this scenario where people landing with an unplanned pregnancy. That is actually the worst nightmare for every nephrologist.
My question is, did you monitor tacrolimus levels during the pregnancy, and did that correlate with your outcome? Because many of them will have tacrolimus low levels during pregnancy, especially near term also.
Yes, sir. Data says that in pregnancy the tacrolimus requirement is increased 20 to 30% in the pregnancy due to upregulation of cytochrome 450.
But did you monitor the levels also?
No, sir. But we usually follow that level, and we used to maintain in between having in post transplant after 4 to 6.
As usual.
Yes, sir. Usually in follow in OPD we are using azathioprine, so we should take the tacrolimus on higher side.
Yeah, one more thing. Okay, congratulations for presenting the honest data. This is something people are a little bit reluctant to speak out in public, that actually we have bad outcomes. I have a comment on the data analysis part. You have compared the creatinine kidney function at different time points. What you did was you did actually 3 t-tests and you have put 3 p-values. So problem is every time you do a statistical test, there is an error. There's an alpha error, and it's 5% when you do it once, and when you keep on doing it again and again, it keeps on accumulating. So to limit the alpha error at 5, you have to use a longitudinal data analysis method. Your numbers might not allow you to use a repeated measures of ANOVA, but probably you can do there's something called mixed methods, where even small numbers you can actually compare. So never actually do a repeated t-testing when you compare longitudinal data. So okay, thank you.
Thank you. Thank you.
Thank you, Dr. Apurva, for your excellent presentation. Next, we will now call Dr. Deepa, SR Nephrology from Government TD Medical College, Alappuzha, for the third presentation.
Good evening, respected chairpersons, teachers and dear friends. I am Deepa KP from Government TD Medical College, Alappuzha, and I am here to present the paper on association between blunted midterm renal hyperfiltration and pregnancy-related outcomes. Early in gestation and persists until delivery due to increased renal plasma flow. It is a measure of kidney function reserve during pregnancy. Effect on pregnancy outcome is poorly studied. So our aim was to find the incidence of blunted MRH and factors influencing its development, and to study the relationship between blunted MRH and pregnancy-related adverse outcomes. So we included all pregnant women attending our obstetric OPD, and women with multifetal pregnancy, GFR less than 60, persistent albuminuria, no baseline creatinine values, and having systemic diseases like diabetes, SLE, and hypertension were excluded. Ours was a prospective cohort study which was done for a period of 18 months, included 210 patients. So after getting the informed consent, detailed history and physical examination were done, including parity and complications during gestation. Baseline creatinine and eGFR values before pregnancy or within 6 weeks post-conception were taken. They were closely monitored, and patients who developed newly detected hypertension before 20 weeks and who lost follow-up were excluded. At 20 weeks, serum creatinine and eGFR was calculated. MRH, midterm renal hyperfiltration, was defined as 30% increase in eGFR from baseline. So cases, pregnant ladies were divided into those having midterm renal hyperfiltration and those having blunted MRH. And they were closely monitored and till the time of delivery, and gestational age, birth weight and mode of delivery were noted. Some of the definitions we included were preeclampsia, which was new onset hypertension with proteinuria or end-organ damage. Preterm delivery, which was defined as delivery before 37 weeks, again divided into moderate to late and very preterm birth. And low birth weight, which was defined as birth weight less than 2.5 kg. Data was analyzed using IBM SPSS 20 software. So 400 cases were screened and 215 cases were selected considering inclusion and exclusion criteria. Baseline eGFR was calculated. They were followed up. Midterm eGFR was calculated for 210 patients, and they were divided into MRH positive and blunted MRH, and they were followed up until delivery. The baseline characteristics were: mean age was 26.55 plus or minus 297, mean creatinine was 0.813, when mean eGFR was 100. Out of the 210 patients, 100 were primipara. At 20 weeks, mean creatinine was 0.53 and eGFR was 131.06. So out of the 210 patients, 134, that is 64% had midterm renal hyperfiltration and 36% had blunted MRH. So on further analysis, we found that increasing age and increasing parity were significantly risk factors for blunted MRH. And on further analysis, we found that out of the 52 preeclampsia patients, 88.5% had blunted MRH. Out of the 50 babies delivered with birth weight between 2 to 2.5 kg, 72% mothers had blunted MRH. Out of the 56 preterm delivery, 82.2 had blunted MRH. And out of the 154 normal term delivery, 80.5% mothers had MRH. So preeclampsia, preterm labor and low birth weight were the outcomes that were studied. Those were significantly associated with MRH. And the relative risk of adverse outcomes with blunted MRH was to the tune of 4.937. So to conclude, in our study, 64% pregnant ladies developed midterm renal hyperfiltration and 36% had blunted MRH, for which age and multiparity were the risk factors. Blunted MRH predicted the development of adverse gestational outcomes with a relative risk of 4.937. The highlight of the study was it was a prospective cohort study. Some of the limitations were it was a small sample size study, and as a tertiary care center, there might be referral bias, and 24-hour creatinine clearance, which was the gold standard, could not be assessed due to cumbersome procedure. For the some of the suggestions were the further research with larger sample size are needed to understand the pathophysiology. Thank you.
GFR estimation. We also did it in our group of population, and we found those patients who had a hyperfiltering response were performing poorly because they believe that there is something called something of diabetes kind of a thing. This hyperfiltering kidneys, and they are causing more injury. And so we observed in those those patients who have blunted response may be probably having an early evidence of renal injury. Those patients who, and when we looked into our data, patients who had GFR between 90 to 120 ml, they've performed very well. But those who had beyond 120 or below that, they performed poorly in maternal and fetal outcomes.
The reference study is Sehun Park et al. Their study had showed a U pattern where it was more than 150, it was a bad, and less than 100 was also bad.
They talked about this hyperfiltering stuff causing.
What was 95% confidence intervals for the relative risk? You told the risk ratio was somewhere around 4. What were the confidence intervals? Because when we say the risk ratio, that actually gives only a part of the picture. You need a confidence intervals also for appropriate interpretation of the risk ratio. Second thing is, you should not have stopped just looking at the risk ratios. What you are trying to do is whether you can use this midterm renal hyperfiltration as a predictor for adverse maternal and gestational, maternal and fetal outcomes. So you should have looked at the sensitivity and specificity and the predictive values as well.
Good study, nicely done, good design. The only thing is, in preeclampsia, where you said that this could predict poor gestational outcomes, fetal outcomes. Did it also predict poor maternal outcomes?
Yes, preeclampsia.
Preeclampsia. It could it predict preeclampsia, or
it was significantly.
It was just an association.
Association.
But you have not seen whether it is a predictor for preeclampsia.
It was association was found.
Specificity also, like I just had a look. Specificity also might be decent.
Just one more thing. So you use the EGFR, no?
Yes.
So the problem with EGFR is not validated in pregnancy at all. So possibly next time you do it, you should use 24-hour creatinine clearance.
Any more questions from the audience? So,
out of your total number of patients that you're taken into account, I think almost, can you just go back to that slide? The GFR was less than 60 in 118 patients, which I found it quite surprising for the previous slide. Out of the 400 patients you have taken into account, I was just wondering why 120 patients had a low baseline GFR. Is there any reason that you could find out? It's quite significant is what I thought looking at the slide. Is there any reason that you could find out why those low GFR?
Actually, I think that is less than, it was less than 80, I think.
Less than 60 or 80?
80.
so thank you, Dr. Deepa. So this is the last presentation. So we'll wind up.
We just have a group session photo. Whoever is over here with all the faculties and the delegates, we can stand over here and the photographer will take a photo. And then after that, we can proceed for the dinner, which is arranged in the ground floor of the auditorium.
Thank you for all your wonderful presentations. This brings us to the end of today's sessions. Thank you all for your participation today. We will be starting tomorrow morning at 7:30 with an interesting quiz session for the postgraduates, followed by an exciting lineup of topics and speakers. We request you all to join us for the dinner in the ground floor hall. Thank you and wish you a great evening.